Welcome, everybody. We are going to get started just with a few quick announcements. Welcome to those joining us via the web as well. Welcome to the last day. I can't believe it's the fourth day already. We're going to encourage you to attend sessions throughout the day, including our closing keynote by Dr. Amiris DePuglia. Amiris is a medical doctor who currently works as an educational consultant and will share an interesting and insightful perspective on living with children with autism. I don't think you guys are going to want to miss it. So the exhibit hall today is open till 1 p.m. Make sure before you leave, you hand in your verification form to the registration desk. Please continue to offer feedback via our Groupio app, and the QR codes are posted at the back for this session. Now, it is my honor to present Dr. Patrick Friman. He received his PhD from the University of Kansas. He is the current Vice President of Behavioral Health at Boys Town and a clinical professor in the Department of Pediatrics at the University of Nebraska School of Medicine. He was formerly on the faculties of Johns Hopkins, University of Pennsylvania, and Creighton Schools of Medicine. He was also formerly the director of the Clinical Psychology Program at the University of Nevada, as well as the associate chairman of the Department of Psychology. He is the former editor of the Journal of Applied Behavior Analysis and the former president of the Association for Behavior Analysis International. He is also on the editorial boards for 6 peer-reviewed journals. He has published more than 180 scientific articles and chapters and 3 books, and he currently writes a regular column on child behavior for Family Spectrum magazine. The focus of his scientific and clinical work is in the area of behavioral pediatrics and behavioral medicine. Dr. Friman's work in behavioral pediatrics is concentrated on the gap between primary medical care for children on one side and referral-based clinical child psychological and psychiatric care on the other. A secondary focus is on adolescent behavior and development, an example of which is a commercially available DVD on adolescence and other temporary mental disorders. He also specializes in consultation regarding workplace issues such as motivation, dealing with difficult people, change, and pathways to success. Having seen Dr. Friman speak at ABAI personally, we're in for a treat. His presidential address there, I must say, was the best I've ever seen. So please welcome Dr. Friman with me.
Thank you. Thank you very much. Thank you for that very flattering introduction. I wrote it. Can you hear me? Can you hear me in the back? Can you guys hear me? Fine. Oh yeah, I'm talking to you. Yes, you can hear me. Nod. Yes. No. Yes. Thank you. All right. Can you see me? You see me? You see me? This is what anxiety looks like. Not bad, right? No, I'm experiencing the physiology of anxiety presently. There's no way to get in front of an audience this size unless you're intoxicated and not experience the physiology of anxiety. And instinct bids me 2 courses of action, because I'm having a threat-based stress response. Instinct bids me 2 courses of action. One, I can attack and kill all of you, or I can just get the hell out of here as fast as I can. But I've learned over the course of my career to override instinct, and that's the essence of what I want to get across today. In my opinion, anxiety is a natural state for our species. The title of my talk is Anxiety, and I called it the psychological equivalent of fever. It really would be better to say the psychological equivalent of body temperature, and that periodically it elevates too high, because the default state of a human being, in my opinion, is an anxious one, which is another term for fear. And I say that you are all afraid. And what allows me to say that with any confidence? Well, you're all clothed. What are you hiding? Why do you have clothes on? What are you afraid of? We're the only member of the mammalian species that puts on outfits. And the reason we do that is to cover up what we look like. So what are we afraid of? What's dangerous about having people see us in our natural state? Maybe it isn't very attractive to see, but maybe it's stunning. Who knows? We're not going to know. That's just my point, is there's so many things that scare us that aren't dangerous that I say that anxiety is a default state for the species. So danger is a ubiquitous human experience. Fear lives in the hearts of men and women, but not all of what we're afraid of is dangerous to our physical well-being. And the term for that I use is anxiety. Now, I just want to issue a caveat because my suspicion is that there are a lot of behavior analysts in the audience. Is that true? But not everybody in the audience is a behavior analyst. I myself am a behavior analyst, and I have bona fides. You know, I was the editor of the journal and president of the association. Some of my best friends are behavior analysts. But I don't talk like a behavior analyst, and I don't strive to. I strive to communicate to the broadest possible audience I can. I will incorporate behavior analytic speech as it serves my purpose, which is to communicate. I am not in business to further behavior analysis in audiences that aren't composed of behavior analysts. I'm not in business to make sure that all language that I use is reinterpreted in the language of behavior analysis. I'm in business to communicate, and I want to communicate about anxiety today. I'll use behavior analytic concepts. I'll use colloquial concepts. I'll grab information from unknown gurus who talk in outrageous terms because they've made the periodic good points. I'll do anything. Really, I'm a prostitute for making a good point. So, if you're a behavior analyst, please bear with me. You might listen in terms of, or from the perspective of, how does this guy communicate these straightforward concepts in colloquial terms? Because I'll be using a lot of colloquial terms. That's my caveat. The anxiety concept wasn't invented by Sigmund Freud, but it was popularized by him. He's one of my intellectual heroes, not just because he's one of the foundational personage in terms of psychology, but because of the quality of his writing and because of the emphasis he placed on history, which is consistent with the emphasis placed on history and behavior analysis. And one of the concepts that he forwarded into our world most forcefully was the concept of anxiety, but he had a very difficult time defining the concept. So here are his attempts. The initial one is the deflection of somatic sexual excitation from the psychical field and in an abnormal use of it due to this deflection. Clear? He didn't find that acceptable either. And so he worked with the definition. 20 years later and change, he comes up with something highly composite that includes particular motor innervations or discharges and certain feelings. Clear? Wasn't clear to him either. He knew he wasn't getting anywhere, he even said so. He says, a certain ambiguity and indefiniteness in a term will not have escaped you, and it didn't escape him either, didn't escape us. But lots of people have had a tough time defining the concept. For example, a notable behavior analyst, Murray Sidman, said you can't define it. Levitt said you can't define it. Naughton said you can't define it. Harnlam, Woolman, Campbell, Kutosh, they're all editors or authors of psychiatric dictionaries, and their definitions of anxiety not only differ across dictionaries, they differ within them. David Barlow, arguably the leading anxiety researcher of the late 20th century, wrote a book called Anxiety. It's about 700 pages. He doesn't even attempt a definition for 100 pages. The definition that he attempts then is 100 or so words long, and it includes many words that themselves are not defined very well. So it's a tricky concept to define unless you're willing to just say it's fear. And I'm going to give you my definition. Negatively reinforced behavior, that should appeal to the behavior analysts in the crowd. emitted in the presence of events that evoke the biology of stress or fear, but that pose minimal risk of harm, like speaking in front of an audience, for example. Now, if you don't like my definition, you can just make up your own. Here's where I got my material. But should we be interested in the concept? Yes, absolutely. It's central. Ubiquitous in psychology, psychiatry, the culture at large, central to all of psychopathology. There's multiple different diagnostic categories. There are journals devoted just to it. It's got the highest lifetime prevalence rate of all the psychiatric disorders. There's 100,000 and counting articles published on anxiety. That's far more than have been published in the science of behavior analysis. And it's central to daily human life. I can create anxiety very easily. All I need to do, I can do it right here. I can grab that microphone and I can walk out into the audience and start making gestures as if I'm going to hand it to somebody. And that will create anxiety in the people that are looking at me thinking they're within my reach. That's all it takes. And would that be dangerous? No. Would you be afraid? Yes. That's what anxiety is to me. Now, I'm going to spend some time just talking about anxiety. I know you folks are interested in the autism spectrum population, and that's our purpose today, is to talk about anxiety in that population. But I want to spend time on anxiety first so that we have a more complete understanding of the concept. I'm going to talk about some research that we've done at Boys Town involving various anxiety disorders in kids that are afflicted with the condition. I'm going to talk about the difficulty in understanding the concept, why it's difficult to understand the concept. But then I'm going to veer into the ASD population, show that it's much more prevalent in that population, speculate about why, talk about anxiety in the caregivers of persons on the spectrum, then talk about what to do about it. Recommendations for parents and caregivers, recommendations for professionals, and come out on the other end with some more examples and maybe time for questions. So here's some obstacles to a complete understanding of the term. First, we just talked about one difficulty, and that is the term itself is imprecise. Another difficulty is its metaphorical basis. This is very hard to grasp. Anxiety is a metaphor. It's not an is, it's an as if. It stems etymologically from the term anguisse, which meant to choke, to not be able to breathe, or to be experiencing the imminent death. Now, when a person is suffering from anxiety, they're not choking. It's as if they're choking. They can breathe. It's as if they can't breathe. They're not dying, but it feels like they're dying. So it's not an is, it's an as if. But we now use it, the term, as an is. I will fall into that trap multiple times throughout the course of this conversation. It's almost like you can't escape it. But I have to remember always, it's just a metaphor. Now, there's another metaphor that we use for similar sorts of responses. For example, when somebody's going to engage in a performance in front of a large audience, so they're going to do something physically risky, they often feel a little fluttering in their stomach, and we refer to that as a feeling of butterflies. Because the way that we communicate our world, when we don't have a good way to define what we're talking about, is to take something that we know well, and then to use that and say, it's like that. This thing I can't talk about very easily, anxiety, is like this. It's choking, not being able to breathe, or dying. The term I was thinking of is butterflies, because we know butterflies, you know, they flutter. And you get this feeling in your stomach, and it feels like fluttering. And you want to tell somebody how you feel, and you don't exactly know how to say what it is, and so you say, it's like I have butterflies in my stomach. But nobody thinks there are actually butterflies in there. It's just a way of communicating the feeling. That's the same domain, semantical domain, that anxiety exists in accurately. It's not is, it's as if. But we talk about it like it's an is, and it leads to what I refer to as an ontological trap. I trick my graduate students, my interns, and my postdocs, even my faculty and my staff on a regular basis, and I lure them into the ontological trap. I recite a number of symptoms. So, for example, I might say, here's a guy, he's got dry mouth, his palms are sweaty, his respiration rate is a little ragged, his heart rate is elevated, and his blood pressure is up a bit, his pupils are constricted, and he's making a lot of quick movements that seem to make no sense. Why is he doing that, do you think? And they're likely to say, well, he's doing that because he's anxious. Well, you see, I don't know if you see the trap or not. Then I go, how do you know he's anxious? Well, because he's doing all that stuff. Well, no. That doesn't answer a why question. That answers a what question. The term anxiety there is a label for what he's doing, not an explanation for what he's doing. For an explanation, we need another set of facts. We only have one set of facts here, and that's all those symptoms I mentioned. I ask for an explanation. That's what a why question is. Why is that happening? They give me a label and say that's why it's happening. No, that's not why it's happening. But you can see that we use that way of thinking a lot. When you say that the reason one of the kids with whom you work acts that particular way and then list any one of the symptoms of autism, and you say they act that way because they have autism, sorry, that's not an explanation. That is a label. That is a description. We still need another set of facts for the explanation. I do that with depression with my students and interns and postdocs. I try to trap them to show them that they need to go further. One of the beauties of behavior analysis is that it is not ever satisfied with one set of facts. It always wants another set of facts. We are in perpetual search of what's called a functional relation, and for a functional relation, you don't have functional relationships with labels. You have a functional relationship with facts. And so we have one set of facts, conditions out in the world, and another set of facts, behaviors emitted by the organism, and a relationship between those two that's correlated highly is a functional relation. That's what we're in search of. It's one of the beauties of the science. But in everyday life, we don't do searches for functional relations. We use labels as explanations, and that's what happens with depression and anxiety, autism, or any one of the conditions listed in the DSM. So it's sort of it's an obstacle to complete understanding, because once you've said the reason he's doing that is because he's anxious, people are satisfied with that. And so it stops the inquiry. And we don't want to stop the inquiry with that term. We want to have that activate the inquiry so we can find out more. So I think of anxiety as a category. That's a useful way to think about it, and it has a lot of members in it. Skinner said there was only one member, and he did some very nice research showing what one of those members was. He called it conditioned suppression. It's pretty easy to create. You establish what's called a free operant baseline. All that means is you let the organism do anything it wants to do without any preparation or attempt to change what it's doing, measure it, then expose the organism to a conditioned aversive stimulus. What you get is a suppression of responses momentarily, because one of the reactions to a threat-based stimulus is freezing while the organism studies the environment. So you get a suppressed rate of responding. That suppressed rate of responding is what Skinner said is anxiety, and you can quantify it. Yes, it is a component of anxiety, but there's more that happens with the organism when they're in the presence of a threat. First they freeze, but then they have two courses of action. I mentioned those earlier. They're instinctually based. One is attack the source of the threat, or the other is get the heck out of there. And that's conditioned activation. And so that's also in the category. And then if it's a human that you're dealing with, there are a whole bunch of thoughts that go along with the threat, like catastrophizing or awfulizing, or thinking how horrible it's going to be, or thinking how terrible it is if you stay. That's all occasioned by the threat stimulus. There's the physiology of fear. We'll talk about that more. And then there's motoric movement, and we talked about some of that. So maybe think of anxiety just as a category, not as an is existing in the world, only as an is existing in language that refers to stuff in the world that we are interested in. I don't mean to be so pedantic, but I want to get some of this stuff out of the way before we get into the meat of the matter. So here, let's try another definition. Anxiety, fear-based avoidance of objects, activities, or events that are not inherently harmful. Here's a whole bunch of synonyms, and I mean these are synonyms. We're talking about the same thing here. Fear, apprehension, uncertainty, uneasiness, foreboding, distress, worry, disquiet, dread, jitters, heebie-jeebies, fretfulness, sitting on pins and needles, cold sweat, nervousness, and I could go on. But I believe you know what I'm talking about. All that is what we refer to as anxiety. It isn't this special psychiatric thing. It's something all humans experience on a regular basis, not just some humans. But for an anxiety disorder, and this is important, to have an anxiety disorder, the anxiety has to disorder the person's life. Being afraid to fly, and I submit to you that a lot of people in this room are afraid to fly, does not mean you have an anxiety disorder. But if you're so afraid of flying that you absolutely won't get anywhere near an airport, that's a disorder. Being afraid of public speaking is completely normal. In fact, it's the #1 human fear. So being afraid of public speaking doesn't mean you have an anxiety disorder. It means you have anxiety, yes. But if you're so afraid of public speaking that even the mere thought of having to do it causes bodily discharges called diarrhea, that would be a disorder. That means this condition is disordering your life, and you have an anxiety disorder. So the anxiety itself is not abnormal at all. It's what we do in response to it that can or cannot be abnormal, that can result in a diagnosis. So here's some signs of maladaptive anxiety. The term excessive is key here. Excessive fear-based avoidance of benign objects or events. I just mentioned excessive avoidance of public speaking is a disordering batch of behavior. Excessive avoidance of air travel is evidence of maladaptive anxiety. Excessive emotional reactions. It's perfectly normal for me when I get in front of an audience to have elevated blood pressure. I can feel it. An elevated heart rate. I can feel that too. My hands don't actually get sweaty. Sometimes my voice gets a little raspy. And sometimes I can feel a difference in my respiration. I can feel that. Like it's a little, not harder to breathe. It's unusual. When people are doing public speaking, sometimes they have to remember to breathe. You have to remember, oh yeah, I need air in order to make sounds come out of my mouth. Also, to keep my body upright. Oh yeah, right, got it. That's, I think, perfectly normal. But you can get excessive reactions, emotional reactions. I mentioned one, any kind of elimination, urinary or fecal. That would be excessive. Whimpering, crying, anger, and we'll talk about various motoric methods of managing the underlying condition, the physiological condition of anxiety. That would be excessive emotional reaction. An excessive need for control. I'm going to talk about that more. I'll just say this much here. If you know an anxious person, they're a control-oriented person. You're still getting away from it. Control is part of the condition. If you know a controlling person, it's very likely underneath their attempts to control is anxiety. Not always. Sometimes it's due to another set of facts, but mostly it's due to underlying fear. And then unresponsive to reason. You can introduce all the facts you want to somebody that's consumed by an anxious response, that's consumed by, they have the emotional reaction, that they're fixated on how awful it would be, and you can tell them how unlikely all you want, and they're still fixated on how awful. You tell them that the odds of the plane going down are 1 in over 1,000,000, and all they can think of is that they don't want to be that one, and they can't get their mind off of it no matter what you say. Then what we have is maladaptive anxiety. It's unresponsive to any attempt to talk them out of it. And then a high frequency of episodes. So avoidance is central to anxiety, and there's a downside to it. First of all, it reinforces notions of danger and prevents learning acceptance. If you don't stay in the presence of whatever it is that scares you, you can never learn about its reinforcing properties. And the idea of it being dangerous, the physiological responding that we have that's consistent with it being dangerous remains intact. It's like we have to put it in colloquial terms, we have to convince the brain that whatever it happens to be, is not dangerous. So I'm continuing to use myself as an example. You guys are not dangerous. You're a friendly audience. But when I walked in the room, you were dangerous to me. In an earlier time in my life, I wouldn't have gotten this far. I wouldn't come up onto the stage. And you would have remained in my mind as a dangerous set of stimuli. But the longer I stand here, the less that seems to be true. This is what's called exposure. There's another definition of exposure, which I'm not using today. I'm not exposing myself to you. I'm being exposed. and you are being exposed to me. And it is lowering the threshold for fear that I have. But if I avoid audiences altogether, then the dangerous message that I get from audiences remains intact, and I continue to have the dangerous responding, the fear-based responding, the anxious responding. So it's a big downside of avoidance. They've shown now in PTSD, you know what PTSD is, post-traumatic stress disorder, that if they can get the person that's been exposed to trauma to re-experience it within a very short period of time, they've narrowed the window down to about 10 or 15 minutes, that the memory of the event reestablishes itself. They don't speak in operant terms. They talk about the brain like it's an independent volitional organism, but it does seem to happen that way. And so the memory reconsolidates itself so that it's more tolerable. In other words, they're showing, using neuroscience, that what we've known for many years, that things like escape extinction are really powerful ways for operant behavior to surface in an adaptive way. It reduces the ability to face other challenges, probably through stimulus generalization and response generalization. Because I don't know if you understand the power of stimulus generalization. You have a situation that's terrifying, and then it's related to other situations that weren't part of the original terror in the 5 following ways. Anything that smells like it, anything that looks like it, anything that sounds like it, anything that feels like it, anything that smells like it. And what are the chances, you know that whole thing about 6 degrees of separation, where you're only like 6 relationships removed from the person sitting next to you in the audience if you don't know them. If you guys talk long enough, you'll find some way that you're connected. That's through relationships. What are the chances that this situation here would have nothing in common with that situation there in those 5 domains? It seems really unlikely that there'd be something about this that either smells like, looks like, sounds like, feels like, or tastes like this. And if that's there, then the possibility of stimulus generalization is there. So the person that is avoiding this, whatever it happens to be, may find themselves also avoiding things over here because it's in some way related in a stimulus fashion to the first initial traumatic situation. And then you get response generalization. So the point I'm making is that avoidance feeds on itself and reduces the confidence that we have to face other challenges in life, and ultimately shrinks life. The fearful life is a small life. Like the epitome of it is agoraphobia, where a person won't even leave their house. That's how big their life is. Just the contours of the domicile where they reside. Anything outside of it is not their world. They won't go into that world. Their life is that small. It's probably the best example there is of stimulus generalization, because everything outside of their home is considered to be dangerous or strange or threatening. So here are the select anxiety disorders. And I'm assuming that you're acquainted with all of them. I didn't know if you wanted me to define any that you don't know. I can pick one out that people have a little difficulty understanding. Obsessive compulsive disorder. Here's how to think of obsessive compulsive disorder. Not quite right syndrome. The world isn't quite right. And I can't do anything until I make it right. And then the ways in which it's not quite right vary. Sometimes it's just too disordered and it needs to be ordered. Sometimes it isn't counted properly and it needs to be counted properly. Sometimes it fails to meet certain hygienic standards, and those must be established before I can go out the door. So I must polish that doorknob with a microbial wipe 37 times before I can go out the door. So the person that's afflicted with this condition has an obsession about the world not being quite right. You might call it an establishing operation, and they are compelled to make the world right. And that is the behavior that becomes more reinforcing because of the operation. And so they make it right, and then they can behave. But until they make it right, they can't behave. They can't move. I don't think any of the other ones need much explanation. Generalized anxiety disorder is just a highly generalized form of anxiety. In other words, it's like stimulus generalization writ large. Everything makes a person nervous. Anything else on here? Agoraphobia, we talked about that. Panic disorder. Panic is a false alarm. But a lot of this stuff is a false alarm. But with panic, you get that very potent threat-based stress response, which basically tells the person that death is imminent. And the brain responds in kind, then the body responds in kind, then the mind responds in kind, and the whole thing devolves into a state that does sometimes approximate death because they can't even breathe. And they begin to feel like they can't breathe, which reinforces the notion that they're going to die, and it feeds on itself. But all of it is based on a false alarm, like a false response to a stimulus in the environment that's actually neutral. So, I have to do a lot of things in my career that Don Baer and Montrose Wolf and Todd Risley, my advisors, told me that I should never do. And one of them involves conducting psychiatric evaluations of kids that come into Boys Town. Because I work at Boys Town, which is in Nebraska. I don't know if you've heard of it before. If you haven't heard of it, your parents have, because they probably saw the movie. There have been 7 movies made about Boys Town. One won an Academy Award. That's the one your parents probably saw. And it's a residential village, not a residential institution. It's a residential village that houses about 500 kids, boys and girls. They're mostly delinquent. They live with surrogate parents 24/7. And we have a large behavioral program that we run based on the work of Montrose Wolf. And it's a very, very successful program. Someday, maybe you'll hear me do a presentation on Boys Town, which I love to do. One of the things I was asked to do was take my staff and do a psychiatric evaluation of every kid coming into Boys Town. Now, what I wanted to do was a behavioral, or a functional assessment of every kid coming into Boys Town. But I'll tell you why that wouldn't have served the purpose and why the psychiatric evaluation did serve the purpose. And I found a very efficient way to do that. It's called the Diagnostic Interview Schedule for Children. It comes in 2 forms. It's computerized. One's for parents, one's for kids. And there was a battle, I guess you'd call it, in the world of child psychiatry to determine which of many computerized psychiatric diagnostic instruments would win out with NIH and get all the grant money, and this is the one that won. And so we entered into a collaboration with David Schaffer, who was one of the architects of the instrument. He's a professor of psychiatry at Columbia University, and he agreed to supply us with these instruments if we would let him have some of the data and work with us on its accumulation. So we did. So every kid coming into Boys Town took this instrument, or took this test, and it approximates the DSM. It basically lists all the symptoms of each psychiatric diagnosis and asks questions related to those, and the kids answer the questions on the computer. And the reason why the computer is useful is because it's been shown beyond the shadow of a doubt that kids will be much more forthcoming with a computer than they will be with a person. That shouldn't surprise anybody, given how computerized the youth world is now. Like if you have a problem with your cell phone or your computer, you can call up the Geek Squad, or you can just hire a teenager and they'll fix it for you. So we administered this test to all these kids. Now, I was going to tell you why it was useful for us. Bear in mind, these are delinquent kids. So they got to go before the judge. All of them have to go before the judge. The judge disposes of their cases in certain ways. The one the judge is most inclined to dispose of, or the disposal method or direction the judge is most inclined to use, is juvenile detention. Now, that's gladiator school. We have these kids living in this residential village, which is programmed according to the dictates of Montrose Wolf, and it's designed to get these kids off the escalator that they were on that leads to hell, and onto the escalator that you and I are on that leads up not to heaven necessarily, but to the bright, shiny world in which we reside. That's the whole game plan. Get them on that escalator and get them up to the world where we are, and get them off the other escalator which leads down to hell. This judge, whoever he is inclined to put them on the down escalator. That's just the way the judicial system works for these young people. But if that judge has material in front of him that says this kid is not just delinquent, but he's suffering from a psychiatric condition called X, Y, or Z, he's inclined to dispose of the case in a different way. How is that? To send them to treatment, which means back to us. So it served us very, very well, especially when kids had lots of diagnostic things that they qualified for. I mean, on one hand, I hate this kind of thinking, but on the other hand, I can't deny the benefit of it. Because I want to see these kids in our program. I don't want to see them in gladiator school. And to the extent that we could show that they were psychiatrically disturbed and not characterologically disturbed, we got to keep them in our program. Am I making sense here? So it's not necessarily a behavior analytic mission, but it is consistent with behavior analytic values. So we found out interesting things. We found out that our kids were, by and large, pretty anxious across all the conditions, which was really, really good news for us. First of all, people don't think of delinquent kids as anxious. They think of them as mean. They think of them as sociopathic. They think of them as aggressive, acquisitive, dishonest, but not anxious. You look at these kids, they might have come out of a gang in South Chicago and came to us that way. You look at the kid all tatted up and leathered up and full of attitude, and you don't think the kid's afraid. You think he's out in the world to make other people afraid. And you're probably right about that. But what we found is that in many, many, many cases, the kid's afraid too. Really useful for us to know this. Why? Well, it's fundamentally the basis for this whole presentation today. Anxiety, when it's discovered, is good news, not bad news. Why? Because we know how to treat it. That doesn't mean that we can get people to do the treatment. This is going to be the most difficult part of the work that anybody does with an anxious person. Getting them to do the treatment is the hard part, and I'm only going to hit upon that ever so briefly today. But what we do know is if they do what we want them to do, they will gradually get better. This was very good news for us. Because we know how to work with anxiety. We know what to do. We don't always know what to do with delinquency. Even Montrose Wolf said, many of these kids, these hardened, delinquent kids, they might need lifelong prosthetics. And he was using the word prosthetic in a metaphorical way. They might need lifelong environmental support in the form of a program like Boys Town just to get by in the world, which is basically thrown in the flag. But if it happens to involve anxiety, they won't need lifelong prosthetics necessarily. They just use or need the kind of treatment that we know how to supply. So here are the kinds of effective treatment. These are all the same. All four of these are the same. Now, if you're a cognitive behavior therapist, then the therapy that you would describe would be exposure and response prevention. If you're a behavior analyst, it's escape extinction. You can already see where we're losing the battle here. I mean, if you had to choose between the two of those, which one are you going to take? I mean, they're the same thing, but one is packaged better. And that's why it's sold better. That's why it's used more widely outside of behavior analysis, even though behavior analysts invented the concept. So if you're a behavior analyst, it's escape extinction. If you're a straight-up old Wolpian behavior therapist, then it's systematic desensitization. And if you're a Friman adherent, it's behavioral inoculation and vaccination, emotional inoculation and vaccination, all the same thing. I'll get to it eventually. But I want to give you some examples of exposure. This is just exposing people to the threatening stimulus, keeping them in the presence of it until it's no longer threatening, or if you want to use it in the behavior analytic way, it's establishing their presence in front of the stimulus and putting escape on extinction as the reinforcer. So, a lot of people, more people than you probably know, are afraid of water, and they're afraid of what lurks within. They think of it as very hideous or extremely dangerous. And so to convince them to get into the water, we need to expose them to what's actually down there. So we start off with very benign, small, beautiful creatures that lurk underneath the surface, and obviously they're not dangerous. Then we intensify the type of exposure that we use, and then we use multiple situations so that it generalizes, and we get very good results from these programs. Some people are terrified of cats for unknown reasons, and they engage in really maladaptive behavior to avoid or escape from cats. And so in our program, we expose them to cats, asking for what I call distal affection, and then proximal affection, and then we really intensify the amount of exposure, and if the patient survives the treatment, we get very, very good results. A lot of children are afraid of the toilet. They're afraid they might fall in, for example. So in our program, we initially, the initial step is to hold them over the aperture and just hold them there so they can't fall in, get them exposed that way. Then we let them sit independently with the aperture closed. Then we let them sit independently with the aperture open, but we distract them by reading to them. And then we intensify the exposure to its maximal degree, and we get really, really good results from this. A lot of kids are afraid of creepy crawlies. And in our program, we expose them to very small creepy crawlies. Then we increase the size of the creepy crawly. Then we increase the proximity of the creepy crawly. And then in the final stage of our program, we maximize the amount of exposure, and we get very good results from this. So let me give you some actual examples. Another assignment I was given at Boys Town is to look at every kid that was going to be terminated from our program and see if there wasn't something in the psychiatric history that I could use and my staff could use to reclaim this kid and prevent him from being terminated from our program. Because remember the escalator, if they're terminated from our program, they go back onto the escalator going down. So the next step down is juvenile detention. And after that, you don't even want to know those steps. So we were energized by this. This is a good use of our services. We get to take a second look at a kid, give him a second chance. It's like the New Testament all over again, which involves redemption. And we found really interesting patterns in the psychiatric findings from the diagnostic interview schedule for children. For example, this young man, this is just data, obviously he's not a man, but this is data from a young man who was 14 years old, freshman in high school, and he was going to be expelled from Boys Town for groping the chests of some of our girls. And of course we'd want that. Many of our girls have been sexually abused, and to be grabbed in that way was traumatizing for them. And we can't have a predator on our premises because we are an open campus. We have no walls, no fences, no locked doors, no security guards, no people trained in takedown exercises or non-lethal self-defense. None of that. This is just a community that's wide open. And so we can't have threatening presences in our community. And when they're threatening our girls, they got to go, unless we can change that pattern of behavior. So I look at this kid's DISC results, the Diagnostic Interview Schedule for Children results, DISC results, and I find that 1, he has Tourette's syndrome, and 2, he has obsessive-compulsive disorder. Then I interview the kid and I find out what's been going on with his chest groping, and it isn't chest groping at all. In his Tourette's syndrome, he has a peculiar motoric tic, because Tourette's always involves motor and vocal tics combined. If somebody has motor and vocal tics combined and they've had it for more than a year, that's Tourette's syndrome. And there are 5 categories of tics that are not part of the diagnosis, but if they're present, it confirms the diagnosis. It's tricky. They aren't part of the diagnostic criteria, but if they're present, you confirm the diagnosis. One you know, coprolalia, which is obscene speech. But one you may not know, copropraxia, which is obscene gesturing. One is echolalia, repeating what somebody else has said. One is echopraxia, which is mimicking the gestures that somebody just exhibited. And one is palilalia, which is saying what you said, saying what you said, saying what you said. This kid had echopraxia. And he had a particular unfortunate version of it. Whenever anybody in front of him touched their chest, he was compelled to touch their chest too. This is his tic. But he also has obsessive-compulsive disorder. Remember what that is? That's not quite right syndrome. So he would touch their chest, but it wouldn't be quite right. So he had to touch their chest again, and that wouldn't be quite right. And he had to touch their chest again, and that wouldn't be quite right. Now, our boys could handle this kid, but our girls had no idea what to do. And so imagine me, like a house parent, seeing this kid grab this girl's chest multiple times. What's he doing? He's obviously groping her. He's abusing her. But that wasn't what was happening. What was happening was he was compelled by a tic and then compelled by this underlying obsessive-compulsive disorder, it's not quite right syndrome, to grab, 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 grab. So in our work with him, now we know what to do. See, I was saying, when we find out it's anxiety, this is good news. We know what to do now. We need to expose him to the situation that evokes this behavior that he engages in because it's negatively reinforced, and cut off the reinforcement. So I had my intern at the time, Doug Woods, who's now an internationally prominent habitat researcher and probably the world's leading Tourette's syndrome expert, sit in front of this kid and touch his chest, inviting him, basically, taunting him. Like what's the word they use for in drug sales? Entrapment. That's what it was. It was entrapment. And the kid would reach for Doug's chest and Doug would block his hand. And they just did this for sessions. And gradually, I mean, initially, the kid would keep his hands to himself, but he was just trembling with what I call a threat-based stress response because he really wanted to touch that chest. I taught my dog Bonkers years ago in Montana to hold a biscuit on his nose for 5 minutes. It took a lot because he's hungry. He wants that biscuit, but he was trained to keep it there. But every fiber of his being is trembling while that biscuit's sitting there because he wants it so badly. And that's what I was seeing in this kid. He wanted to touch that chest so badly, but he didn't. And gradually, that whole thing just went away. And he stopped all of that, stopped touching altogether, and we completely eliminated that problem. Now, these data were published in a premier psychiatry journal, the Journal of the American Academy of Child and Adolescent Psychiatry. For those of you that are research-oriented, you probably realize there's no design here. It's not even an A-B. This is just B. So why would they publish it when there's no control whatsoever? Because that condition had never been reported that way before. This was very, very provocative data. And we found another kid on campus with the same kind of pattern, except it didn't involve chests and touching, it involved ordering, and did the same kind of intervention and got the same kind of results, this time with an experimental design, and published those data in JAMA. Now here's a nice young man, handsome young man, dressed up well, smiling, very pleasing to look at. Looks like he's applying for a job. And here is his clinical description. Above average IQ, suspicious of adults, anxious in all such situations, especially school, a pervasive fear of public failure. A quote from his psychiatric evaluation: habitually resorts to avoidance or escape strategies to avoid embarrassment, very controlling. In fact, the psychiatrist that evaluated him said he is developing a tendency to control those around him in order to reduce his nervousness around those individuals. And if this isn't circumvented, it will become a lifestyle for this young man that could potentially be risky. And it turned out that it was risky. This was him when he came to Boys Town. This is him not long ago. So Charles Manson is obviously a monster. And clearly he's not a success story from Boys Town. But he came to Boys Town in the 50s. Had he come when we did the diagnostic interview for Schedule for Children, it might have been an entirely different story. Yes, he's a monster. I'm not trying to suggest that's not the case. But nobody's born a monster. He was born with a predisposition for social anxiety, and he became a very controlling individual in order to control his anxiety. He had a very unfortunate combination of conditions. 1, conduct disorder, and 2, social anxiety. And as Brian Iwata has shown, once we understand the function of behavior, we can approach it more appropriately. So for example, he discovered that a lot of the self-injurious behavior they were seeing in individuals at the Kennedy Institute years ago had an avoidant function. But the thing about self-injurious behavior is it attracts attention, it attracts sympathy, it attracts action, which drives the self-injury, because the message is, leave me alone, not come and help me out. And it's the same thing with the conduct disorder with Charles Manson. It's like, he's leave me alone. But the more he engages in conduct, the more attention his behavior draws, the more he engages in conduct, the more he tries to control, and here he is now, a monster. But if we could have gotten access to him, because back then they had no idea what social phobia or social anxiety really was. They didn't know how to treat it. That treatment hadn't been invented yet. And if we could have gotten him now, I'm not saying that we work miracles, because this wouldn't take a miracle. Once we know it's anxiety, it doesn't take a miracle anymore, because we know how to work with it. We just have to get the person to participate. So, knowing this, we had a young man at Boys Town who was going to be expelled from the program. He was a very aggressive 15-year-old boy. He was a year behind in school, in our middle school. And he was one of the most athletic kids on our entire campus. And he had been aggressive with his family teachers and his educational teachers. Whenever they administered a point fine, he would get aggressive with them. And we can't have kids beating up on our teachers. So if they start doing that, we can't stop it, they got to go. But I get to look at his records. I get to look at the DISC results, and I see that he qualifies for conduct disorder. We knew that. He also qualifies for social anxiety. We did not know that. He did not present himself like an anxious kid. And so I interviewed him, and he told me that he didn't know what was going on, and whenever they gave him a point fine and there were other people around, he just went berserk. That's his word. And so the intervention for the kid was me. Oh, sorry, I got the wrong data set. There. This thing is a little hypersensitive, by the way. It's a brand new battery in here. I went around to his teachers and his family teachers and asked them, told them basically, whenever you do a point fine with this kid, do it privately. That's all. That was the whole intervention. Is just do it just like you would do with an adult. We don't take adults in public and discipline them. I mean, I have a lot of people working for me. I periodically have to give critical feedback, but I never do it publicly. I always do it privately. But for some reason, when we're giving kids critical feedback, like in high school, it seems very appropriate just to give it to them wherever they happen to be. And this is the most socially anxious time of life, like in middle school and in high school. And we want to do that privately for all kids. Well, I didn't campaign for that, but I campaigned for private disciplinary sessions with this kid, and everybody agreed because we wanted to save him, and we did, because his aggressive episodes went to 0 and maintained for the entire school year. Like I say, when we know it's anxiety, that's good news for us. Here's this generalized anxiety and habit disorder. The kid here was 15. He was completing the diagnostic interview schedule for children on the computer. I walked by to see how he was doing. Blood is coming out of his mouth. I know it's unpleasant to do these psychiatric evaluations, but I don't think they cause internal bleeding. That's my thought. I see this, and I'm concerned about the kid, so I shut down the test and ask him what's going on. He says whenever he takes tests, he gets nervous. In fact, he's nervous all the time. And then when he gets nervous, he bites the inside of his cheek, and that was happening. So we just did a little intervention for him, which involved teaching him relaxation skills, which I'll talk about later when we talk about ASD, and gave him a competing response, something to do instead of biting his cheek, which was chewing gum. And I got permission for him to chew gum in school and at home, at will, willy-nilly. And the title of our paper in Java is, Relax and Try This Instead. And all those data points, those are blood spots from swabbing out the inside of his mouth. Here's a very common form of fear, anxiety, which is children's resistance to bedtime. Not all of it's fear-based, but a lot of it is. Humans are afraid when they're in the dark. So we take young children who love to be part of the family and place them in a darkened room, close the door and leave them there, and it scares them. And they cry out, and they call out, and sometimes they come out. And we can teach them not to do that. We know how to do that. We know how to teach them not to do that. How? Just leave them there with the door shut until they stop it. 4 or 5 days, it's over. What's the problem then? Nobody will do it. They simply won't. It's like the parents can't ignore that crying out and calling out, particularly, but not only mom. Why would that be? I can speculate. That's an operant that's been shaped over time. So that kid would be in that room many, many times trying out ways to get mom to come. Lots of different sounds, many of which were ignored. Nothing. 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 Mom! Nothing. But he'd keep on forming responses until finally one got mom to come. Okay, keep that. You follow what I'm saying? Until finally he got an operant that's composed of the very things that have been demonstrated to be things mom absolutely can't ignore. And then that's what the kid uses. That's a very hard bond to break. Some of it's fear-based. So the intervention that would work is escape extinction, but the parents won't do it. So what do we do instead? We give the kid a bedtime pass. So the kid now has a pass that he can use to summon his parents or go out and find them. They can summon them like servants or go out and find them like nomad. And he can make one, or she can make one request, like for a drink or a hug or look under the bed. And then they surrender the pass, and back in bed, escape extinction ensues. And what happens is we don't get that that extinction burst that makes it so difficult to do escape extinction, that operantly formed extinction burst that makes it a challenge. We don't get that. In fact, most of the time, kids don't even use the pass. Why would that be? I really don't know. Maybe they're laying in bed thinking, whew, sure hate to have the boogeyman come, not have my pass. We also don't get that burst because, and Wayne Fisher has shown this, that if you integrate a differential reinforcement of alternative behavior, DRA, with escape extinction, you don't get an extinction burst. Why? Well, because the organism has a reinforceable option, and they don't need to burst in order to get what they're after. So that pass is basically that. And we have quite a bit of data indicating that this is, I'm not going to go through the data sets, I'll just show you. This is a randomized clinical trial, for example, with many kids in it, and the crying out, calling out, and coming out from the bedroom all went down to 0 level. So my point here is we have a lot of methods for working, or effective methods for working with anxiety once we know it's the case. The trick is ultimately getting people to follow the treatment, but we do have a treatment that works. So here, I'm about ready to veer into ASD. And is now a good time for a break? You're gonna have to take a break. I can talk like this for 8 hours. So you can't look to me in order to determine when to have a break. I'm asking you. Would now be an okay time? All right. Come back. What, 5 or 10 minutes? 10 minutes. Hi.
Hi.
Now? Oh, excuse me. Now? Okay. Hello, everyone. I'm back. Are you back? If you can hear me, I guess you are. And if you can't hear me, I guess you're not. Oh. I'm going to get started. So I'm moving into anxiety and autism spectrum disorders, ASD. And you see here the prevalence estimate is 40% for youth 18 and younger. What that means is that it's almost the average case. Like almost the average ASD kid is anxious or has an anxiety disorder. It's like the average marriage in America ends in divorce because there's a 50% divorce rate. This is a 40% prevalence rate for anxiety for youth, so it's almost the average case. And let's look at some specifics. For specific categories with prevalence estimates for ASD and non-ASD populations. For separation anxiety, in the ASD population it's 10%, and in a non-ASD population 5%. For generalized anxiety disorder it's 20 versus 5. For specific phobia it's 30% versus 12. And for social anxiety it's 40% versus 12. So it's clear from the prevalence estimates that persons on the spectrum are predisposed to anxiety more so than people not on the spectrum, and they're particularly predisposed to social anxiety. So why is that? Is it there's something about their limbic system that makes it hypersensitive? Is there something about their brain development that makes them over-responsive to fear stimuli? Is there something in the genetics of the disorder that predisposes them to fear or lowers the threshold for fear? Is there something central to the diagnosis itself that's related to fear? I don't know any of that, but I am going to speculate about what I think might be involved, talking about the limited extent to which persons on the spectrum achieve certain developmental milestones early in life or master certain developmental processes, and the failure to do these things predisposes people to social anxiety later. We'll start off with secure attachment. This has been very well established that, especially by Mary Ainsworth, but not only Mary Ainsworth, that infants that are very securely attached to their mother will venture out into the world, into strange situations further, more frequently, and stay longer than infants that are not securely attached to their mother. It's as if the infant that is securely attached to its mother brings the security of the attachment out into the world with them, and it makes it less of a strange and scary place, and so they go further, stay longer, and do it more often. Whereas the insecurely attached infant, it's as if they bring the insecurity of their attachment out into the world with them, and they don't get very far. In fact, they won't even leave visual range of the mother. So one of the heartbreaking features of ASD, as you know, is the difficulty that these young kids have establishing a secure attachment, a secure emotional attachment to their caregivers. And so they're, on that basis, predisposed to interact with the world in an insecure way, the social world in particular. Interactive play is a developmental process. Initially, children don't interact with each other. They play independently. They do isolate play, but gradually they play with each other. And that play involves giving and taking. It involves generative activities. It involves creative activities. They quickly learn that they can have more fun when playing with each other than they can have on their own. And all of that is done with objects early. Later, they begin to play in other ways. So as young children, we played with objects, our toys. Later in life, we play with other objects that are called words, which are the compositional elements for conversation, for interaction, for social relationship. The foundation for that is all set early through interactive play. And if you don't have the interactive play early, then you don't get that foundational relationship process that will, in an inductive sense, develop what you do later as you interact with people and you're not using objects anymore. And these young ASD kids, they're not big on interactive play. They have very limited shared play. And as a result, they're not benefiting from participating in that process, taking the benefits of the process out into their life with them as they age so they can use it in more difficult situations that don't involve objects but involve words and conversation. And then learning interpersonal boundaries. Really critical. And these are learned very, very early. You and I, we don't even think about them anymore unless they're violated. We just instinctively, it seems, not really, it's operantly, but it seems instinctive, that we just recognize boundaries and we don't violate them, and if we do, we usually get negative, critical, or social feedback. But that starts early. Initially, these kids, they don't recognize any boundaries. They're pushing on each other's face to stand up, and they're grabbing each other's toys and grabbing each other's bodies. And if you've ever worked in a preschool or a daycare, you know that there's a lot of bonking, and there's a lot of biting, and there's a lot of screaming. What's all that about? That's school, and its purpose is to teach interpersonal boundaries. That's how they do it. Basically, that's kids saying, get out of my airspace, get out of my territory. It's like you wake up in the morning and you hear birds singing in your backyard, and you think, oh, that's so wonderful, they're so happy. They're not. That is not what that is. That is birds saying, get out of my territory, stay away from my nest, stay away from my mate, or I will peck your eyes out. And they're just doing it with a song. And that's the same thing when you're listening to kids play. I mean, it sounds cheery from a distance, but up close, there's a lot of teaching going on because these interpersonal boundaries are taught by the kids, not by us. They are training each other in very harsh ways that would never, never be approved by a human rights committee to teach kids to stay away. Because we don't get to bite kids in the face to get them to stop doing stuff, but they do. And so we just naturally, instinctively know these now. So for example, we are going to do something today that if you think about it long and hard, you realize that somewhere along the way we've learned something and forgot that we learned it. And what does it involve? It involves getting into a metal receptacle that it travels vertically in this hotel called an elevator. And it will be filled frequently, and we do this a lot, with flesh-eating mammals that we don't know. This is, again, we're the only species that can do this. There's no other species that you could put into an elevator and have it all go peacefully. Only we can do this, and the reason we can do this is because we know the boundary-based rules in the elevator. You may not think about it, but you follow them. And here's basically what they are. Go into the elevator, don't look at anybody, don't talk to anybody, and certainly don't touch anybody. Swiftly turn around and press the button for your floor. Then stare at the numbers that are over the door as if the secrets of the universe were contained there. Keep your eye on the numbers to try and get those secrets until the door opens for your floor, and then exit the elevator, don't look back, and don't say anything, go to your room. We follow those rules pretty well. You can violate them a little, you can violate them a lot. And if you violate them a lot, you better be drunk because you need a reason. And that's the only acceptable reason that people in the elevator will tolerate. If it's any other reason, they won't tolerate it. No, here's the thing. What if you didn't know the rules? Because I'm thinking that that elevator is sort of like the world for the ASD kid. And they don't learn those boundary-based rules early in life because they're not engaged in very interactive play. They're in their own world. Perspective taking for them is more of a challenge to learn than it is for your typically developing kid. And if you don't have that perspective taking notion that you and I have, then it's very hard to take the perspective of the other into account as you interact with them. So what if you didn't know any of the rules, you got into the elevator and you stared at everybody, or didn't turn around, you just started talking. Two people, maybe not the people. You missed your floor because you didn't turn around and look at the numbers behind you. It would be really unpleasant. The people in the elevator would make the elevator ride very uncomfortable. You'd get frowns, stares, maybe people would say, turn around, stop staring at me, don't touch me. And I'm thinking that when ASD kids venture out into the elevator I'm calling the world, they don't know the boundary-based rules as well as you and I do. So they end up violating a lot of boundary-based rules, and as a result, they get a lot of negative social consequences that you and I might not even see, which makes the world for them a stranger and scarier place. They already have a difficult time out there because they weren't securely attached to begin with, and so the world doesn't look as friendly to them. It doesn't look as safe to them. This is anxiety, which is fear of stuff that's not dangerous, and the social world isn't truly dangerous. And just because somebody doesn't like us doesn't mean it's going to hurt us in any way other than emotionally, and that's just anxiety. So that's one of the thoughts. Now, that doesn't affect all ASD persons this way. It just predisposes them for anxiety because of this developmental process that's not necessarily mastered. And then finally, there's the learning formal social roles and rules. You and I know these really well. We know to keep our hands to ourselves. We know that you only engage in so much eye contact. There's only so many places we're allowed to stare at people when we are talking to them. We know that when they talk to us, we talk back to them. We know not to talk too long. We know to stop when somebody says stop. We know to stop when somebody says no. We know we're supposed to listen. I could go on and on. And there are ways we're supposed to behave. All of this just seems natural to us because we've been in a developmental process that allowed us to learn this without ever anybody putting it into a course that we took a test on. The test was done socially, and we passed these tests. You and I do something every day that's really, really dangerous. Really dangerous. And we don't even think about it. You don't even give it a second thought. What is it? It's get into an automobile and drive it around. They weigh about 2 tons, thereabouts, and we drive them at 30, 40, 50, 60, 70, even 80 miles an hour, and hundreds, maybe thousands of other people are doing the same thing. We're out there in that crowd, and we don't even think about it. And if one of these things hits us, that's it for us. The quality of our life, if not our life itself, is gone, and yet we don't even think about it. Well, how can I say that? Well, we're texting, we're talking on the phone, we're eating, we're drinking coffee, we're listening to music, we're daydreaming, we're looking at our day planner. We might even have a video embedded in the dash. We're staring at that. We're doing everything but pay attention to driving. We're behaving as if it's really, truly safe. It doesn't even cross our mind unless something really unusual happens, like an ice storm. How is that possible? How is it so safe? Because we know the rules. And we follow them pretty closely. I'm not saying nobody in here has had a traffic ticket, because I know that's not true. Somehow I know that. But I'm saying generally we follow the rules. We stay in our lane, we signal a turn, we yield frequently, we stop at red lights, go at green, maybe slow down a little at a yellow, yield. We never go the wrong way in a one-way. We follow the rules pretty generally, and as a result, you're unlucky, I guess. It's unusual to have more than one car wreck in a lifetime. What if you didn't know the rules? What if you had no idea about any of these rules? You didn't know what the signs meant, you didn't know what the colors meant, you didn't know what the directional arrows meant, you didn't know what the lanes meant, you didn't know about speed limits, you know nothing. And you're out there in your motorized vehicle driving at those speeds. What are the chances you're going to get to where you're going without an accident? It's kind of my thought about what the social world might be like for persons on the spectrum. They don't know the rules as well as you and I know the rules, and so they're bumping into stuff far more than you and I bump into stuff. And for them, that world can become a strange and scary place. And the ratio of their pleasant to unpleasant interactions is much different than yours and mine. The ratio of their pleasant to unpleasant interactions is in favor of the unpleasant interactions, and it's no wonder they want to avoid it. Not because it's inherently part of their condition, but it's part of their learning experiences up through the developmental processes of their lives. There are social interactional ratio researchers. They usually study marriage, but not only marriage. We also do it on our campus. And what they've shown is that in a marriage, if the pleasant to unpleasant interactional ratio is 5 to 1 or higher, that is 5 pleasant interactions for every unpleasant interaction on a daily basis in the marriage is 5 to 1 or higher, that marriage is immune to all the known causes of divorce, including infidelity. But if that ratio falls down to 1 to 1 or lower, then divorce is almost a 100% probability. And if it doesn't happen legally, it will definitely happen emotionally and sometimes physically. That same thing appears to occur just in social situations of another sort, because we've done research like that on our campus. If we can get our kids up to a 5 or 6 to 1 ratio of point award versus point fine, we immunize them against all the kinds of things that could get them expelled from our program. So this is a rhetorical question, but what do you suppose the interactional ratio in the social world is for the average ASD person? How many pleasant interactions are they having out there? And I mean that without us as their guide. They're just out in the world on their own, not with you at their side making sure it goes well. Because if you're there actually improving the ratio. That's part of your job, is to make sure that the world isn't too painful for them. But that means that they need you. They're not learning to do it on their own. They got to have you by their side. If they're out in the world on their own, what's their ratio? And my suspicion is, given how much they don't know about the kinds of rules and roles that you and I know, it's probably frequently the wrong kind of ratio, the kind of ratio that results in divorce, in avoidance, if you want to put it that way. And divorce is like the ultimate in avoidance of one person. So let me talk a little bit about, somebody asked me this at the break, about fear and non-fear-based avoidance. First of all, avoidance is central to anxiety. Central. It's also central to ASD. But in anxiety, there's only one kind of avoidance, fear-based avoidance. In ASD, there are two kinds of avoidance, fear and non-fear-based avoidance, and I'm only talking about one today. A lot of you might be interested in another. In fact, the person that talked to me at the break realized I wasn't going to talk about non-fear-based avoidance, so she asked permission to go to another session. I mean, I said, it's fine. You got to maximize your benefit here and graze a little bit. I understand that. But I want you to know, I am just here today to talk about anxiety, and there's a lot of stuff in ASD that doesn't involve anxiety, but still involves avoidance. In very simple terms, the fear-based avoidance involves avoiding stuff that you're afraid of, but that other stuff is avoiding stuff you don't like. And I don't know how to get people to like stuff they don't like. I mean, I can compose ways, I can use learning theory and theoretically get them to like, I suppose, program liking in. Like, you know, if somebody doesn't like they don't like knee-high soda, I can get them to like it. I just have to make sure they have nothing to drink for 4 days, and they're going to love it. I mean, there are ways to do this, I suppose, powerful establishing operations. But beyond that, and those are hard to program. Let me give you a sense of what I'm talking about. So I'm going to start with non-fear-based avoidance. Is it safe to say that most of the people, if not all the people in this room, don't like cold spam? Now, I apologize if you love it. But I haven't met anybody in your tribe yet. I'm not, there probably is one. In fact, if you're from Hawaii, there's a good chance you might like cold spam, because there's a lot of spam in Hawaii. They serve it there. And same in Australia, oddly enough. But I think it's safe to say most people don't like cold spam. But just to make the point a little more, even add to the credibility of what I'm saying, let's add whipped cream on top of it. So cold spam, whipped cream, now chocolate sauce, now ketchup, now mustard, now pickles, and now sprinkles. So, would you avoid that? I have a feeling that you would. Would you be afraid of it? I don't think you would. I mean, it's disgusting, of course, but it's not fearsome. And so if we encouraged you to approach it, you'd resist, but not like power, to be like, no, get that out of here, that kind of resistance. That's like non-fear-based avoidance. But let me give you the example of fear-based avoidance. In Chicago, there's a hotel, I think it's the Hyatt, could be the Hilton, I get those two mixed up. It's got 28 floors. The top floor is devoted to the presidential suite, which is a penthouse suite. And the reason they call it that is for many, many years, when the President of the United States was in Chicago, he stayed in that hotel room. It's 4,000 square feet, 2 stories, it's got a helicopter pad. That's where the President lands. He doesn't go into the lobby like you and I do. When the President isn't there and a conference is held there, they will often let the incoming President of that conference stay in that suite. And that's what happened when the ABAI, the Association for Behavioral Analysis International, had its conference there years ago. Janet Twyman was the incoming president. She had that suite. We had a cocktail party in her room. And after we had a couple of drinks, some of us migrated out to the helicopter pad. Not everybody would go. Some of us went out to the helicopter pad. Some just looked at it but wouldn't go on it. Some of us went on it. So we're a little afraid already, because 28 stories up, you're out in the sky looking down into Chicago, and it's nighttime. And so most people wouldn't go onto the pad itself. And then the game plan when you're on the pad itself was to go to the edge. So you're on the edge looking straight down 28 stories into Chicago, down into the streets of Chicago. It's a little spooky, but you can't fall. Not possible, because there's wire mesh that extends all the way out, protecting all the way around it. But it's black and you can't see it. So you get the illusion of standing over open air when you're really not. It's perfectly safe, but only about 4 people would go near the edge. I'm not necessarily afraid of heights, so I would do that. But let's say you are afraid of heights, and you're about here, there's the edge. We start nudging you towards the edge. How much resistance are we going to get? It's not going to be the same kind of resistance that we had to the spam. There's a whole different kind of resistance going on over here, because this is a life and death reaction. That's what we have. That's what we're dealing with. We're not dealing with this, I don't like it, don't make me. We're dealing with, no, get it away, no. Now, just because it's more intense and more powerful doesn't mean we can't work with it. I say this kind of avoidance is easier to work with than that kind of avoidance. Am I making sense here? What we're talking about is a fear-based or threat-based stress response. At the risk of driving the behavior analysts in the room a little bit nutty, I'm going to use some dime store neurology here to explain what I'm talking about. If called upon, I could put it all into operant terms. Just telling you that. I just don't have to now. I'm trying to convey a message that doesn't need an operant basis. So I'm saying there are 3 centers in the brain. There's a reward center, there's a threat center, and there's a management center. When the threat center or the reward center is in charge, trouble almost always follows. That's why adolescent life is so chaotic, because their management center, whose purpose is to manage the organism when it's in the thrall of the reward center or the threat center, is offline most of the time and very underdeveloped. So they need access to our management center because theirs doesn't work very well. And that's why you get that crazy behavior in adolescence, why they drive 80 miles an hour in a 50, why they do those crazy drugs, why they stay up like way, way past bedtime, why they do all those things that make no sense. They're doing it for the sensation of it all, for the thrill of it all. That's why they, what do adolescents have against mailboxes? You ever thought about that? That it's thrilling to destroy them. That's what they have. It's not because they hate mail. They love destroying stuff. It's thrilling to them. And that's when the reward center is in charge. And all that angst you get in adolescence, all the worry and all the moods, that's when the threat center is in charge. And their management center is pretty weak. What I want to talk about now is just the threat center. When the threat center is activated by a threatening stimulus in the environment, a batch of stuff happens. The first thing is stress hormones are released into the body. That's cortisol and epinephrine, some adrenaline. Those recruit fuel because the stress response, which is what we're talking about, is just the body preparing for action. The stress response is physiological, not psychological. People think of stress as psychological. It's not. It's physiological. The reaction to stress is psychological. Stress itself is technically physiological. So stress hormones recruit fuel. That fuel is glucose. It comes from the muscles and the liver. It needs to be metabolized, burned for energy. So we need oxygen for that. That means respiration rate goes up. You start breathing more to get more air into the system. Once the fuel has been metabolized, it's now energy. It needs to be distributed into the system. That's the capillary system. Blood pressure and heart rate go up. What we have now is a brick on the accelerator. The car is still stationary. You follow what I'm saying? The engine is running. That's the first thing that happens in the presence of a threat. What's the threat? So you get freezing initially where the organism studies the environment to determine only one of two things: kill, run. So it's freeze, kill, or run. It's really uncomfortable. If you can execute the action that's called up, you get relief, you get negative reinforcement. If you can't, you're stuck with the engine running. We've got to figure out a way to get that to not run anymore, because it's really, this is actually happening. So what do you do? What does a person do when they're in that state and they can't kill or run? But the stress response is activated. Well, this or if you're lower on the spectrum, it's like that energy has to be dissipated somehow. It's really uncomfortable to have it racing through the body. Action is called up. This is a powerful, powerful establishing operation. Also what happens is a response range narrows and inflexibility ensues. So it doesn't really occur to people what their options are. It can. We can work with this. We can train people to be in the presence of genuine physical threat and not have a threat-based stress response. It's all over the place. So let's imagine you standing at the plate in a baseball diamond, and the people I'm talking to are people that haven't played very much baseball. You know what it is, but you haven't played much. So you're at the plate, and on the mound is a 6'5" professional baseball pitcher from the best team in the country. I don't know who it might be. So they look like they're just towering over you because they're so tall and they're close to you. And then they throw their fastball, which is 98 miles an hour, and they throw it very close to your face, and it just has a little bit of an edge to it as it goes over the plate as it comes by. What are the chances you're just going to stand there and stare at that ball and see if you can hit it, as opposed to, oh my God, Jesus, which would be the stress response and, getting out of there. That's you and I. Watch a baseball game. Those baseball players, they stand there and study that ball. They're not afraid of it at all. Not at all. Their heart rate doesn't go up. They don't get any of that epinephrine. They don't get any of that cortisol. They are trained through repeated exposure to look at the ball and not have a stress-based threat response. They're not born that way. As little kids, they jumped out of the way. They learned to not jump out of the way. They learned to override that response. Or let's say that you're in the ring with a professional boxer and he throws a punch. What are the chances you're going to stare at that punch to see if it's coming at your face or not, or as opposed to, oh my God, Jesus, he's going to hit me. But if you are a professional boxer and the other professional boxer throws the punch, you barely move. You study that punch. You get no stress-based threat response. You're looking for information. Everything slows down for you, and you just move just a little bit out of the way and return the punch. Now, that's not instinctive. It's instinctive to duck. It's instinctive to get away. It's instinctive to either attack brutally or run away. To study the situation, that's not instinctive. You've got to learn that. We can learn to override these things. Navy SEALs are trained to be in the presence of a genuine physical threat and not have a stress-based threat response. People hold guns right in their faces with the hammer cocked, and they don't have the reaction that you and I would have. They study the entire environment. They don't just focus on the gun. Their range of responses is broad. The epinephrine's not in their system. They measure these things. They have trained these individuals to not have that response. All of us can learn this with the right training techniques. If you and I go hiking in Glacier National Park, it's in Montana. I'm from Montana. Land where men are men and so are the women. Tough country. So we go hiking in Glacier National Park. I backpack a lot in Montana, so I know the country pretty well. We go around a bend, and there's a grizzly bear on the trail. Presumably, that'll be the first grizzly you've ever seen in the wild, and you're going to have a threat-based stress response. You'll focus on the claws, you'll focus on the teeth, you'll focus on the odor, and you'll focus on the size. You'll freeze, and then you'll think, can I outrun Friman? No, you'll want to run. That's the first instinct you're going to have. You're going to want to run. I don't have that. I look at that bear. I study the situation. What I see behind the bear is a bunch of huckleberry bushes loaded down with fruit. And I know immediately, as long as you keep your cool, we're fine. Why? Because I know a little bit about the matching law. The matching law is a theory of choice. And what it shows us is the probability of making a choice is a function of the probability of reinforcement. And so in this situation, there are two sources of reinforcement called food. One is you and I, and one are those huckleberries. The probability of reinforcement for you and I is probably 50, 60% at best, because we can run away, we can attack, we can climb trees. It's going to require effort on the bear's part. But the probability of reinforcement of those huckleberries, 100%. So unless we do something to activate the bear's threat-based stress response, the bear's going to eat those huckleberries and forget about us. But I come by that information by not having the threat-based stress response. You had yours. You're at much greater risk than I am because you're likely to do exactly the wrong thing in that situation. And that's frequently what happens when people are anxious, is they do the wrong thing in a situation. If they were able to stay in their management center longer, they could study the situation and come up with a more appropriate response. Am I making any sense here? Okay. This should say signs of social anxiety in the social interactions of very young ASD children. So we're talking about ASD children, although it could be typically developing children too, but signs of anxiety in their social interactions. And you've seen this. You see the bossiness, you see the scripting, telling other kids how it's supposed to go, frustration whenever the play shifts in the way it's not supposed to go that way, interrupting the play of others, or avoiding it altogether. What's all that about? Control. It's about control. I said earlier that if you know an anxious person, you know a controlling person. You know a controlling person, they're probably anxious on some level. What is that? Why does control have such an operant power? Well, remember the stress-based threat response, and it comes in lots of levels. You can have a mild one. Like when I got up on stage this morning, I had a relatively mild one. But you can have one that's just completely very intense and completely dominates all your behavior for an extended period. So the person is controlling their environment because they can't control that feeling. You get that, the bricks on the accelerator, like I said, the engine is running, the pulse is racing, the respiration rate is saying, pupils are constricted. It's very, very uncomfortable. Nobody likes it. You can't execute the actions to get rid of it. What do you do instead? Well, you manage it as best you can, but you also attempt going forward to control the world so it doesn't evoke that response. You can't control the feeling, so you control the world that makes you feel that way. So these kids, the anxious ones, are controlling the play of others because it bothers them to see the play go that way. They don't understand why it's going that way. It's not going according to Hoyle. It's not going the way I like it. It's not going the way I'm used to it. It's unusual to me. It's strange to me. And I don't know anything about sharing. I don't know anything about interaction. I just want it to go this way because this is the way I feel really comfortable, but that way makes me uncomfortable. And they keep doing it, so I have to control them so they don't do it so it doesn't do it to me. That's what that's about. It's an attempt to control the world so the world doesn't create that feeling. Now look for signs of anxiety in their play. And all these things I have listed here. The repetitive ordering, like you get lining up, sorting, stacking, knocking over. You get movement of objects, repetitive body movements, saying what somebody else has said back to them, emotional reactions to thwarting. All kids show those signs. All kids do that. The word here that's key is excessive. Excessive repetitive ordering. Excessive movement of objects. Excessive body movement. What's all that about? That isn't about play. You watch the play, sometimes it looks like it's play. It looks like it's an attempt to create, it's an attempt to generate, it's an attempt to have fun. But you watch closely, if it's a sign of anxiety, it doesn't have anything to do with fun. It has to do with management, self-management. They're engaging in behavior that they can control, which allows them to get a sense of control because their body is making them feel they're out of control. But here's just one example. You tell Tommy, typically developing Tommy, Tommy, pick up your toys. And Tommy says, pick up my toys? Echolalia. Perfectly natural. But you tell the ASD Tommy, Tommy, pick up your toys. And Tommy says, pick up my toys, 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 pick up my toys. That's a whole different thing that's going on there. That echolalia there is an attempt to manage the feeling that's evoked by the command. You're trying to get his body under control. And also, simultaneously, trying to get the world not to do that to him anymore. I'm not saying this happens with all ASD kids. It's just a sign of it. We're looking for signs of when it is anxiety, because when it is anxiety, it's good news. Signs of anxiety in elementary school, age children, that was young children. Same thing with the control, except it extends now to the teacher. They're correct the teacher, argue with the teacher, bargain with the teacher in order to have the class go the way they want it to go, the way that they're comfortable with. They're controlling that environment as best they can. They'll take over the play of others. And their participation will be deficient gradually because they'll be unsuccessful at doing this or punished for doing it. And they get those heightened emotional reactions when it just doesn't go their way. This leads us up to adolescence. Now they've been wearing this, bearing up under this for a long time. It's starting to wear them down. It's starting to wear them down. It's just a difficult way to live. It requires so much energy to have a successful day. And it just gets worse for them. There's so much an adolescent ASD person doesn't know. That is such a difficult time in life. Who wants to go back and be a teenager again? I'm not saying go back and know what you know now. Who wouldn't want that? I'm saying go back and do it all over again, unless you were a quarterback or a cheerleader. You know, and even then, who wants to go back? That's a very, very difficult time in our social development. Things take on a very heightened importance that they never took on before. And it helps to know how to negotiate that landscape. They don't. Like, for example, teasing and bantering is critical to adolescent life. It's part of how they relate to each other. But you know, ASD kids, they're not that big on teasing and bantering. They don't get the timing of it. They don't get the tone of it. They take it too literally. So just as an example, let's say you got a group of kids, adolescent kids. One of them has Asperger's, Tommy. These kids are teasing each other. So Bill teases Jim. They all laugh. Jim teases Bob. They all laugh. Bob teases Bill. They all laugh. And then the Asperger's kid, Tommy, he teases Jim. Nobody laughs. Everybody stares at Tommy like, what was that? Because the tone was wrong, the timing was wrong, it didn't sound like teasing, it sounded like a true insult, like he meant it. Now poor old Tommy, he's like, well, wait a minute, everybody was laughing. at this. I just was doing, like he might go home and tell his mother, I just did what they were doing, and they all laughed when they did it, and then they didn't laugh when I did it. What's wrong with that? Because he just doesn't know. And that world becomes even stranger than it already was and more fearsome. And they frequently don't get the joke. They just don't get the joke. Like, think of what a joke is. A joke is a series of rhetorical events that are logically sequenced to produce an expectation. And the higher the expectation, the bigger the build-up, the better the joke's going to be. So you build up this expectation with this logical sequence, and then at the very end, something entirely unexpected happens. And the degree of its unexpectedness is the degree of its humor. It's like, oh my God, I just didn't see that coming. But you got your ASD kid who follows the logical sequence and then gets the thing that fell out of the sequence. They're like, wait a minute, that didn't go there. Well, let me give you an example. This is not a good joke. It's an okay joke. But let's say you got a group of adolescent kids, one of whom has got Asperger's. And I'm part of the group, and I'm telling this joke. So I started off, I go, a guy walks into a library, and the ASD kid, he likes this. You know, he's got Asperger's, he loves libraries, so he's tuned right in. And the guy walks up to the librarian and says, I'd like a Bud Light, please. And the Asperger's kid is offended by this. You can't get a beer in a library, and you shouldn't ask. You should not ask for a beer in a library. This is wrong. And the librarian says to the guy, I'm sorry, sir. This is a library. And the Asperger kid loves this. He's wrong, she's right, the world is a terrific place. And the guy goes, oh, sorry. I'd like a Bud Light, please. Everybody laughs, except the Asperger kid. He goes, wait a minute, he's still asking for a beer in the library. What's going on? And they think it's funny. He might not say anything there. He goes home and he tells his mom about it. Like, what is the deal? They think it's funny if you drink in libraries. Or a personal example. When I was 19, by the way, you could drink in Montana when you're 18 when this happened. I'm 19 years old. Sunday, I'm sitting around with my buddies. We're at the University of Montana College. We've got nothing to do. About 11 o'clock in the morning. We have a little money. We decided to buy a couple cases of beer and watch football. And so we sent the eldest member of our group, who wasn't in college, his name was Gordon Turcotte. Believe me, he wouldn't care if I told you his name. He's proud of this. Who was a little older than us, a little more sophisticated. He was an American Indian, and he loved making fun of white people because he could. He's like the smartest guy we knew. And so we gave him the money, and he's supposed to go get the beer. Well, he took the money and never came back. We waited all day. And then a week goes by. It's Sunday again. It's about 11 o'clock. We're trying to figure out what we're going to do for the day. And in walks Gordon Turcotte with 2 cases of beer. And everybody played it straight. You follow what I'm saying? Everybody acted like he had just left. He acted like he just left. We acted like he just left. We stayed in character for like 5 minutes. We all got a beer, asked what was going on at the grocery store. People were like, the tension is heightening because he's been gone for a week. Not 5 minutes. And then we just jump on him and slug him a couple of times, and everybody's howling at how funny that was. But if you had Asperger's, would you be able to pick up on the subtlety of that? Or would you think, hey man, you were gone for a week. That's wrong. I mean, you just would not be able to pick up on the subtlety of the humor that adolescents engage in ongoingly, which kind of greases the wheels of their day-to-day life. And so what we see as a sign of anxiety in these adolescents with ASD is they start becoming dependent upon their parents and the adults. Well, that is not a good sign in adolescence. Adolescence is all about becoming independent from the adults and from the parents. You know, the 16-year-old adolescent thinks, I could make it on my own if they just get out of my way. And I want to make it on my own. I don't need them anymore. They completely block out all that we do for them to make sure that they stay alive on a day-to-day basis, and they just think that they could make it on their own. But the adolescent ASD kid who's anxious, boy, they don't want any of that, because they hang with the adults, and the adults are nice to them. They listen, and they don't make fun of them, and the adults take pains to make sure that they're understood. They don't try to trip the kid up like the adolescents do. And so gradually these anxious adolescent kids start to just stay home and stay around the parents, and they'll stay there until they're they'll stay there until they're 45. You know, this is one of the things you're going to have to deal with, is that world to them looks not safer and safer. It starts to look more and more dangerous, and that whole process has to be circumvented unless you want to have them living with you forever. Then there's parent and caretaker anxiety. I want to go back to let me go back to that. There's one more thing. There's something I guess you should know. There's another thing that a person that gets that threat-based stress response frequently can do. When you freeze, study, attack, withdraw. But if it's chronic, there's one more option. What is it? Just shut it down. Just shut it down. It's what they call learned helplessness or learned hopelessness, which is a foundational component of depression. And it's why anxiety and depression are so related with each other, is that people that are chronically anxious end up feeling like the world is actually hopeless, or they have there's a certain kind of thinking that goes along with depression and involves these three things. There's something wrong with me, there's nothing I can do about it, it's going to last forever. And that kind of thinking can lead to a kind of a learned hopelessness and just give up. And so some of these kids will just get depressed. Just that anxiety will just transform itself or devolve into depression. Now we've got a whole different set of problems on our hands. So the parent and caretaker anxiety, here are some signs of that. Helicoptering, just checking, hovering, making sure everything's okay. Or cocooning, meaning preventing them from getting out into the world where the world can get to them. Or what I'm calling low distress tolerance. Now what I'm talking about here with distress tolerance, somebody was talking to me about something related to this at the break. The distress tolerance I'm talking about isn't our distress, it's our tolerance for their distress. How much tolerance for their distress do we have? Because this is really, really important. A mother of one has limited stress tolerance usually. She responds to all the distress of her infant. But a mother of 12, she doesn't respond to distress. Just because somebody's distressed doesn't mean she's going to go over there and deal with it. If it ain't broke or hemorrhaging, that's you. They're on their own. Because she doesn't have the resources for that. She can't respond to all the distress in the world of these kids. And so she's very good at triaging and very good at selecting what needs attention and what doesn't. And it turns out it's a really good program for child development because kids end up having to do a lot of stuff on their own. As a result, they learn to do stuff on their own. And one of the things that they learn is to manage their own distress. I used to do these developmental assessments a long time ago. I loved doing them for little tiny kids, like 3, 4, 5, 6 months of age. And of course, to do the test, I got to have the mom in there because they can't sit there on their own. So they're sitting on mom's lap. I have no problem testing the kid. I got problems with mom. I got to have her keep her hands to herself. Because, see, what we're looking at is cognition in real time, real problem solving. And there's no effort on the part of the infant to hide that they're thinking. You and I try to pretend like we're not thinking because we want to make it look easy. They haven't learned that yet. They're just struggling with these problems. And what are the problems like? Well, one problem is I set 2 blocks down in front of them, 2 red blocks. And they're looking at those blocks, and man, they like what they see. And they got 2 block grabbers right here, but they're not exactly sure what those are for. I mean, this is thinking. They're like, what have I got to work with here? Oh. It's like, so they grabbed the blocks. Now they got them in both hands. Well, I got a 3rd block. So I set that down. These blocks are out of sight, out of mind. These block grabbers are unavailable. And there's a very exciting object on that table. And you can watch them. They're studying it. They're thinking. And to pass the test, they just have to make any effort whatsoever to pick that block up. They can get down and try and bite it, and that counts. Just because I'm looking for problem solving, that's all. Well, mom can't take it. I gotta, no, because she'll nudge the kid or go, use your hands, or, and I go, no, mom, I'm not testing you. I'm pretty darn sure you could pick the block up. I'm testing your son. But it's her low distress tolerance that I'm dealing with. That's what we deal with kids with ASD in general and kids with anxious responding in ASD in particular. Let's see here. Relatedly, unintentional anxiety signals. Questioning, you know, everything okay, hon? Checking, just checking to make sure everything's all right. Now, let's say that you got a kid, he's got a 36 on the ACT, 4.5 grade point average, quarterback or head cheerleader, Eagle Scout, 4 social clubs, lots of friends, part-time job. How often do you check on that kid? You know, how do you go, everything okay, honey? No, you don't have to check on that kid. The kid's handled completely. Here's my question. Is that what it takes? What does it take to have the kid be okay? I'll tell you what, I'm okay. I'm not kidding you. I am 100% okay. Does that mean I'm mistake-free? Absolutely not. I've made mistakes while standing up here. I make mistakes every day. I have setbacks every day. I do stuff that I've told myself I wasn't going to do, and I still do it. And I'm okay. I make mistakes, and I'm okay. I screw up, and I'm okay. I break my own rules, and I'm okay. It's a stand I have about me. I'm fine, and I'm a guy who makes mistakes. But the standard we have for kids sometimes is like they can't make mistakes and be okay at the same time. They can't wet their pants and be okay at the same time. They can't have a meltdown on the bus and be okay at the same time. They can't punch somebody in the face and be okay at the same time. They can't get an F and be okay at the same time. They can't scream at the teacher and be okay at the same time. Why not? Why not? Why can't they be okay? Because what we have here is they're going to be okay someday. This is coming from their primary caregiver. Well, what's the message there? Well, the message there is that they're not okay now. Well, that's coming from the most powerful source of emotional influence in their life, whose stand is, my son or my daughter is not okay. Guess who gets the message? The recipient of all that. So what if it were flipped around and the person was, my son's okay. Yes, he wet his pants. Yes, he screamed at the teacher. Yes, he got an F. Yes, he got kicked off the bus. Yes, he blew up at the soccer game because they lost. And he's okay. So he's getting a very powerful message from the most powerful source of messages in his life that he's okay. Guess who gets the message? So, not talking about a change in procedure or practice. I'm talking about a change in perspective, like a stand that the kid's okay. And that stand could mute some anxiety, not directly, indirectly. Am I making sense here still? Now, some dilemmas for parents and caregivers. These are ongoing dilemmas. You know what I'm talking about far more than I know what I'm talking about here, because I'm not working with or living with kids on the spectrum. So I don't have to face these kinds of issues. But you ongoingly have to face these kinds of issues. How much noise do you allow in the house? I mean, they want things really quiet, but they've got a sibling with a stereo. Or you got a dad with a lawnmower. Or you got neighbors that like party, or they got neighbors with a barking dog. So the parent has to struggle with this. The game plan should be to get them used to at least some. You know, to gradually introduce them, because they're not going to live in a silent world. They're not going to live in a house with cotton ball walls later. We're going to prepare them for the noise-based world, but we don't want to do too much at one time. But I think people make mistakes with this with infants. Like, somebody has a newborn, you go to their house and they go, shh, baby's sleeping, baby's asleep. That's a mistake. That is a mistake, because kids are forming sleep associations. And if they form an association with silence, well, then silence is necessary for sleep. And I have this image of my dad when I was growing up. My dad was an air traffic controller. He had these midnight shifts, 11 to 7. So he'd come home and go to bed, but not in his bedroom. Not in my mom and dad's bedroom. He'd lay on the couch with an Afghan over him, and I'd get up in the morning, my mom's vacuuming around the couch. And he's sound asleep while the vacuum's running all around him. And he just, apparently his mother must have conditioned him to sleep through noise. Now, my parents didn't condition me to sleep through noise. I wish they would have. But noise is one of those deals. It's how much you want to get them accustomed to. You want to get them accustomed to silence? Okay, that's what they're going to have to keep the peace. Or gradually introduce noise. Same with homework. They hate homework. They got to do some. Maybe create bite-sized chunks, work with it a little bit. There's going to be a problem there. You know, the parent knows if I bring the homework out, he's going to have a meltdown. So what do? Not bring the homework out? Well, that's a dilemma. Same with animal-free house. There won't be an animal-free world. I mean, maybe we can have a snail or or a ginkgo or a chameleon, something to introduce animals into the house. Foods, or you can just let them eat the macaroni, ice cream, milk, and those little fish crackers. That's it. I mean, that's what they love. But they're not going to be able to eat that forever. You have to introduce some new foods. How many do you do? How often? Play dates. You know what happens if they go? They could get that phone call and come pick them up because they're crying in the bathroom. So does that mean no play dates? Well, how are they going to learn to successfully negotiate a play date if they never go on one? The parent is always stuck in the middle of these things. Competition. If they lose, you know what happens. So what do? No competition? Because the world won't do that for them. They leave the house, they're going to go into competitive situations. If we prevent them from being in competitive situations, which is avoidance, which means they never get accustomed to competition. Outings, no outings. I mean, they go in an outing, they're at risk for having to bring them back home because it just didn't go very well, but does that mean no outings? Again, this is just a dilemma for the parent and the caregiver. Compulsions. They're going to have them. So, do we let them? I mean, if you try to stop them from their compulsions, and their compulsions are management strategies. So they're managing that internal state with these compulsions. So there's high motivation to engage in them, but they also look a little aberrant. And so the question is, do we let them have the compulsion, or do we try to program it out of their repertoire? I don't like those kinds of forced choices. I'm always looking in the middle. What's in the middle that we can work with? Maybe we can let them have some of the compulsions. For example, I've probably done more research on thumb sucking than anybody that ever lived. Not because I'm so, I guess, perspicacious when it comes to research, but because nobody's interested in thumb sucking. But here's the deal. I finally hit on an intervention that works. As long as the kid does it privately, I don't care. If nobody sees it, we don't care. Because thumb sucking leads to problematic health outcomes. But if it's done privately, it's not possible to do it so much it'll hurt anything. It obviously can't hurt their social life, can't hurt their teeth, can't hurt their thumb. So if they do it privately, fine. So that's our middle ground. I'm not trying to get rid of thumb sucking, I'm trying to make it private. And we have some behaviors that people would probably arrest us if we engage in public, but we do it privately. You know what I'm talking about. Right? We all have some of those. And we've learned that, well, okay, we can't do that out in the, in the parking lot. And maybe you can put the compulsion there, maybe that. You can have some of it, we just can't have it at school. I don't know. Anyway, the point I was making is that the parents and caregivers are always dealing with this kind of thing, and change, how much not change. Dilemmas for professionals, by these I mean pretty much school teachers or teachers, because they have the same thing. How much do they encourage participation, exposure, and bravery? How much avoidance or withdrawal? So how much playtime? What happens if they have to play with other kids? It can go badly, but they really should learn to play with other kids. Competition, school involves a lot of competition, but you know how they are if they lose. But does that mean we set it up so they always win? It doesn't help them with competition. School assemblies, it's like, for the ASD kid, the classroom is safe space because the rules are in place, and it's really obvious when the rules are broken. There's the teacher, and the teacher's there to catch the kids breaking the rules so the kid is safe. But as soon as that bell rings and they leave that classroom and they go into that hallway, remember the hallway in high school? Remember the hallway? Not safe. Because there aren't enough teachers to supervise that milling through that hallway to catch all the misbehavior that occurs. So you're at risk in the hallway, even if you're typically developing, but you're not an athlete. You're maybe a little on the geeky side. How would I know about this? You're in that hallway, you're not actually safe. And if you're an ASD kid and you stand out, and you're in that hallway, you're not safe. And when you go to the assembly, even more is the case. You can get away with more in an assembly because there just aren't enough teachers to catch the kids doing this stuff. And so the kid's at risk in the assembly. Do you require him? Because he or she knows that if the teacher's not around, they're at risk. Field trips, even more or even less supervision, more possibility of something really embarrassing or worse to happen. And so do we encourage them to go knowing full well they're in peril? Well, we've got to at least work with that. And this perfectionism stuff. I mean, the kids, the teachers have just put in all this energy to get the other kids to get the answer right. And now they got to put in all this energy to get this kid to get the answer wrong. It just goes against the grain. At least accept the fact that you make mistakes. So let's go to strategies for parents and caregivers. Praise and attend to brave behavior, ignore more non-brave behavior. This is really tough. This is just a variant of something that you know well, which is called catch them being good. You got to do this on purpose because appropriate behavior has no apparent survival value. Therefore, we don't pay attention to it. Inappropriate behavior has survival implications, so we always pay attention to that. 1 + 1 = 2, 2 + 2 = 4, 3 + 3 = 6, 4 + 4 = 8, 5 + 5 = 127. Only one of those gets attention. Why not the other 4? They're not important? Well, they don't occur as important. But the 5 + 5 = 124, we got to attend to that. And that's kind of how the world is for kids, is that their misbehavior naturally recruits our attention, and their appropriate behavior sinks beneath awareness, and it gets no water and no fertilizer, so to speak. Whereas the inappropriate behavior gets water and fertilizer, which I call attention. I'll give you an example. Let's say I call up a mother. She's got a 2-year-old and a 4-year-old. I'm a friend of hers. It's 3 o'clock in the afternoon. She's a stay-at-home mom. She is desperate for an adult conversation, I guarantee it. She's been playing slapjack, crazy eights, and hide the bunny all day. She would take a telemarketer just about now, just to talk to an adult. But it's me, it's her friend. And so I call her, I say hi, she says hi, and then she looks to see where the kids are. And there they are on the couch, right in front of her where she can see them. 4-year-old's reading the book, thumbing the pages. 2-year-old, it's got her little dolly, her eyes are kind of droopy, and she's humming to herself. They're separated. She sees right where they are. What happens to that phone call? Well, it goes on and on. They're handled. I've got my friend on the line. A reinforcer has surfaced. So what do they get for that appropriate behavior? They get nothing. They get absolutely nothing. But what if the 4-year-old lights the 2-year-old's hair on fire? What happens to that phone call? That phone call's over. And what are the kids going to get? An abundant amount of attention. And it'll all be negative, but a negative in a context of nothing is a positive because something's better than nothing. So we're watering and fertilizing inappropriate behavior by giving it attention on an ongoing basis. You don't believe what I'm saying? At the break, call up somebody you know has small children at home, keep them on the phone, and listen to what happens. Because the kids already know that bell is a discriminative stimulus for inappropriate behavior. Because you'll either get attention or you'll get mom off the phone. But if you behave well, you get absolutely nothing. And that's the world for kids. And that's potentially the world for the ASD kid when they engage in non-brave behavior. That gets our attention. When they engage in brave behavior, we're like, oh, finally. I've been looking for that. It needs attention. And the kind of attention, oh, that's important too. The kind of attention. Sympathetic attention. Boy, you got to be careful with that stuff. Because human beings become habitually attracted to or develop habits with commodities that have 2 properties. One is relieve pain, and the other is supply pleasure. Any commodity that relieves pain and supplies pleasure is very habit-forming. Now, I'll give you some examples. Percocet, Percodan, Vicodin, Dilaudid, and Demerol. So you can get that stuff, but you have to be fairly seriously in pain, and you only get 1 prescription. You don't get it renewed because it is so profoundly habit-forming. Well, here's another commodity that supplies pleasure and reduces pain. Parental sympathy. That's its purpose. It's, oh, honey, come here. Oh, geez, come on, sit on mom's lap. Yeah, it's okay. That's taking pain away. But it's physical proximity, it's nurturing, it's affection, it's also supplying pleasure. I'll give you an example, a personal example. I was like 8 years old. I'd been ice skating in Montana. It's dead of winter. It was terribly cold. Montana cold, not Pennsylvania cold. In Montana, we don't use the wind chill factor. We don't want to scare people. So it's really, really cold. It's getting dark, and I'm ice skating in a pond 2 blocks from my house. I sit down, take off my skates, cut my finger, and it starts to bleed because my index finger. Initially it hurts, but then something really cool is happening. The blood is freezing. And so I'm like, oh man. And I decide I'm going to make a blood sickle and take it and show it to my brother. You know what I'm saying? This is having fun with no money in Montana. So I'm all the way home. I'm like this. And my plan is to show it to him. He's 11 months younger. Show it to him and then smear it on his face. This is going to be so cool. So I get there. Until I get to the front porch, I look in the window. There's my mom. She's knitting. And instantly, I'm like, oh, look at that, my finger. And even as it was happening, I'm like, what are you doing? It's like it came out of me without me even doing it. That's the power of that attention. I got in the presence of that powerful source of reinforcement, and it completely altered my response set, even though I had planfully put it into action. All I'm saying is that when you attend to that non-brave behavior, it's important not to use too much of that habit-relieving or habit-producing stuff. Model brave behavior and use role reversal. You know what? You and I, we got this thing going on where we got to pretend like we got it handled. Looking good, being right. Everything's cool. Doesn't bother me any. When it's not the case at all. We don't let people in on the stuff that makes us really nervous. We act like we're not. We act like it's just easy. We act like, people prepare for talks and then tell people they didn't. So you see them give the talk and it's great, and they go, oh, I didn't even practice. And you think, oh man, you must have something special. When actually they're hiding their humanity. And I think for these ASD kids, it's good for them to see some of that in us. It's good for them to see that we are managing distress in our own lives, and that we are just like they are in that respect, except we go one step further and do the thing even though we feel that way. We feel the fear and we do it anyway, but we do feel the fear. The game plan for our relationship should not be not showing them that we feel the fear. Show them that we feel the fear, and then show them that we'll engage in the thing. See, that's courage. If you're not afraid of it, doesn't matter what it is, if you're not afraid of it, no courage is involved. I mean, yeah, if you throw yourself on a landmine, okay. But if you weren't afraid, that isn't courage. Courage involves being afraid and doing it anyway. And we want kids to see our courage so they can have a model. And also, we can do like reverse role reversal. Like, just ask them for their advice. Hey, honey, I'm going to go to this is a little party that these adults at work are throwing tonight. I don't know them very well. Really nervous about going. I got to go. The boss is going to be there. I don't know. Do you have any advice for me to how to get in there and, do okay? I mean, just kind of bring them in as a consultant on our nervous problem, and you might hear some things that they have been thinking about this kind of thing that you can, I guess, reinforce because they will have some thoughts along these lines. Allocate responsibility, encourage independence, allow mistakes, kind of talk in that direction with the dilemmas. Let them play soccer. Yes, they might scream at the coach. Yes, they're going to melt down if they lose, possibly. But how are they going to learn? Let them take a chance. Let them erase the board if you're in school. Let them call a friend. They're going to make mistakes, no question. Is that so wrong? The person that can make friends with failure, that's the person that's probably going to succeed because they're not afraid of failure. It's the fear of failure is the number one obstacle to success. You talk to successful business people, and they'll all tell you that the key to their success has been their failures because they learned from those failures. And they were able to take what they learned and use it to build a success. You ever heard of Albert Ellis? He's the founder of what's called rational emotive therapy. Very famous in his day. He's deceased now. He gave an interesting talk once. He talked about learning how to date successfully. He was not a very physically attractive man, but he wanted to go out with really, really physically attractive women. Hey, I know that formula. So he decided The obstacle for him would be fear of rejection. His rational emotive therapy had him realize that's an irrational position to take. So he just decided he's just going to start asking women out constantly. So he did. And yes, tons of rejection. But he just went to the next one. And it was for him, it was like Groundhog Day. Every time he did it, he got better at it, and better at it, and better at it. And pretty soon, he used all the information he gathered from all that rejection, and he started getting successes left and right until he became so good at that, nobody would say no to him. And it wasn't because of his fame. It was because of what he had learned by all those mistakes. He made rejection part of the formula for success. And that's just the case I'm making here, is we got to allow as much of that as you can tolerate into the lives of these kids, realizing that their mistakes aren't the end of the world necessarily. It'll just look like it. Emotional coaching, that's just getting them, like sitting down and letting them talk about their life and not doing anything to correct it, not doing anything to advise it, just getting it and letting them know it's okay. You want to see how this is done well? Go on YouTube, look up the name Carl Rogers, see if you can't watch a session of his or have him talk about his sessions, because that was his position. If you're a behavior analyst, what he was advocating is unconditional reinforcement, non-contingent reinforcement. But he talked about it differently, better. Unconditional positive regard, how does that sound? Versus non-contingent reinforcement. They're both the same thing. One just sounds better than the other. But behavior analysts really have a way of making it sound like we're always in the laboratory. So what he's saying is, what human beings want is to be known. But none of us tell everybody or anybody everything. Well, what if you could? What if you could tell somebody everything? All those stuff that you hide, all those mistakes that you've made, all those thoughts that you wish you didn't have, all those, everything. You just could tell another person all that stuff, and they totally accepted you. They didn't judge any of it. They didn't give you any advice. They just listened and approved. What if you could have that? Wouldn't that be nice? And that's kind of what I'm saying with emotional coaching. These kids need an emotional coach. They need somebody that will just listen to them. It can't be school 24/7. They have to just be certain times in their day. Set reachable goals and use proportional rewards. Slice the stuff up into small steps. You probably already know how to do this. I can use one example. I used to work at the Boulder River School and Hospital in Montana. We're housed moderately, back then, this is the term they used, moderately to profoundly retarded. That's the way they talked back then. Men in the cottage where I worked. And I had to teach them adaptive living skills. And so I learned about backward chaining. I presume you know backward chaining. So let's say I'm teaching Gary Bearsy, who I did teach how to make a bed, to make a bed. So the way we did is I made the bed myself, and then I pulled back one flap of the cover. That's it. Right over the one pillow. And I go, Gary, make your bed. Pulls the flap over. All right, Gary, you made your bed. And I just work my way backwards. It's errorless learning. All the way until all the covers are laying on the ground, and I make the same command, and he makes the bed from scratch. But he started way on the front end, doing very little and working backwards, and he got the same amount of rewards for each step. Now, that's key to the kind of programs I'm going to recommend for exposure. The steps are critical. If the steps are too big, the program's over. Create opportunities for change. I do that. When, just change something. Move the chair. Have the time. I have two doors I can come out when I pick up somebody in the waiting room, and if I have a Asperger's kid that I'm seeing, sometimes I'll come out a different door. And I have two chairs in front of my desk and a couch. I'll move that stuff just a little bit. They'll look at it. Okay. It's like, but they're getting used to change. I mean, there's lots of ways to look for this. Change up the timing, change up the location, change up the tonality, just introduce change as much as possible. Schedule worry time. I like to do this with all anxious clients, not just ASD kids. Like, I want you to really get into this. I want you to just think about how awful it is and how terrible it is, and if everybody dies, you'll be all alone. Whatever it is you have on your mind, I really want you to get into it. And I want you to do it at 5:15. I want you to do it for 15 minutes. And 5:15 happens to be the time when his favorite program's on. So I'm programming worry time, not saying don't do it, not saying don't worry. I'm saying worry, 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 have some worry. But have it now. And what I get, is resistance to worry, which I'm building a repertoire here. I'm building an operant, so to speak. And if they do worry for 15 minutes, fine, to get it out of their system. If they fight me on worrying, then I've got them fighting me about worrying, which is exactly where I want them. Incorporate intense or unusual interests. This is what I was thinking about with the compulsive behavior. Like, I work with a kid, he's 25 now. I started working with him when he was like 17. He has this, like that. This is exactly what it sounds like. I came over to his dad's house and I heard that in the kitchen. What the heck is that? Oh, that's Luke. He's doing his compulsion. Oh, I go in there and Luke's, and they let him as a reward for whatever. He only can do it in the kitchen, and they let him do it as long as he wants, as long as it doesn't interfere with other stuff. I thought, that is genius. That you're not taking that away from him. It's an intense interest. The interest in doing it will probably never go away. Why not use it? Why not hook it up? It's not going to hurt him socially. It's not going to hurt his schedule because it's not allowed to. Well, nobody's going to see it except for Luke. I saw it, but I was a guest in the house and I was already working with him, so they let me see it. They won't let other people that come into the house see Luke doing his thing. So that's what I'm saying is we need sources of reinforcement, powerful sources of reinforcement, and one of the ways to identify sources of reinforcement is just to watch what people do. And if they do something a lot, it's probably reinforcing. So exposure, extinction, desensitization, these are strategies for professionals. I'm going to lump that into this. So here are strategies for professionals. I'll go through this fairly quickly, just in the interest of time. Start off with medication. I'm not saying you're going to give people medication. I'm saying if you're the professional, you're going to spend more time with the client than the physician is, so you better be acquainted with medication. So you can kind of guide your client in who to ask, how to understand it, whether it makes sense. And it does make sense, just not as a cure. So the benzodiazepines are the ones that are most likely to be prescribed. We've got to be careful of those because they have pain-relieving and pleasure-producing properties. Therefore, they are very habit-forming. There is a percentage of people in this room that have these. So you people know what I'm talking about. These are easy to get because they provide very, very quick symptom relief. People that are afraid of flying but still fly usually have these. That doesn't mean they take them. It gives them a sense of control to have them. So they got two in their purse or their pocket. Won't fly without it, but unless turbulence hits, they won't take them either. But it just gives them that reassurance that if the you know what hits the fan, I got my diazepine. So physicians like to use these because they're so fast-acting, because they get results fairly quickly. But we need people to be acquainted with their habit-forming properties, and they are not curative, they're just stabilizing. They allow us to work more effectively with the person. Same with these antidepressants. They're not going to cure anxiety conditions, but they will stabilize the person so we can work with them more effectively, and therefore we can potentially cure them. And then beta blockers, I don't know if you know what those are. Those are performance-enhancing drugs that are no longer allowed on the PGA. It reduces heart rate. So I don't know, anybody that golfs, you know what the yips are? Yips, where you get two, like professional golfer, one of the best golfers in the world, can't make a 4-foot putt even though he tries 10 times. Why? Because he's totally in his head. His heart rate's racing. Lots on the line. They give him one of those beta blockers, make it every time. You can't tell you can't even feel it. It doesn't have no psychotropic properties at all. It just reduces heart rate and makes performance more likely. Pablo Casals, have you heard of him? Suffered from terrible stage fright. Took beta blockers, work. Carly Simon, same deal. And physicians that I have worked with over the years who have to give grand rounds, they frequently take beta blockers before they give their grand rounds because it helps with performance anxiety. And it can help certain situations for ASD kids. They're not habit-forming. It's just something that can help them get through difficult situations where heart racing might be part of the problem. Bear in mind, the drugs don't cure. They manage symptoms so we can work with people or give them the experiences that will cure them. This is all I'm doing now. This is all I'm recommending. If you're going to work with people that are anxious, then learn as much as you can about anxiety. Learn to talk about it in a very colloquial way, kind of like I'm talking about it now, in a very understandable way. I try, when I'm learning something, I learn it technically. I try to find the behavior analytic version of it and master that as quickly as I can. Then I need a clinical psychology version. I master that as quickly as I can. And then I need a mom version. That's my mom, because she doesn't understand behavior analytic speech. She doesn't understand clinical psychology speech, but she understands, mom speech. And so if she wants me to talk about what I do and I want her to understand, I got to put it in those terms. That's what I say. Understand anxiety, put it in mom language, and then talk to your clients using mom language about that condition so they understand what it is. And what I've told you today is it's just fear of stuff that's not dangerous. Anybody can understand that. So my point is, health education should be part of the intervention. And then I externalize the thing. This goes against something I said earlier, because I said it's not an it, but when I'm working with kids, I make it into an it. Because I want to talk about it, not them. So the kid and I are taking it on, and it needs a name. I'm externalizing it outside of them. So we're doing battle with it. It just happens to be their fear. But I ask them to name it, and they always give it, I want an insulting, critical name. Like back when Lord of the Rings was big, like every other kid I worked with called theirs Gollum. Is that it's ugly little creature. So just externalize the thing. That allows us to, talk about it more without talking about the kid. I don't know if you know this about these medications, particularly the SSRIs, the benzodiazepines. They don't put anything into our bodies. They arrange for what's in our bodies to be released or unreleased at different levels. Do you know that? Like the SSRIs, like Prozac, it doesn't put anything into our body. It makes the already existing serotonin more freely available. It prevents its uptake. Selective serotonin reuptake inhibitors. And this, the same thing with the addictive drugs. They don't put anything in our bodies. They release stuff in our bodies that's already there. So knowing that suggests that there might be other ways to get these things released into our bodies without taking a pill. Maybe you could engage in behavior that would release this stuff. And if you've ever heard or experienced what's called a runner's high, that's all that is you engage in that behavior and it results in the release of something that's already there, a pleasure-producing hormone. So that's what these things do. Like these methods, this meditative methods, relaxative, I made that word up, methods, the mindfulness, it results in the release of what you might call calming hormones into the body. And to the extent that a person can get good at this kind of thing, they don't have to also have that other kind of medication that you take by a pill form, which has more side effects. So, so bear in mind, we're dealing with a threat-based stress response. And I'll just tell you a little bit about how focused breathing can help with that, and not with your client. This is for you. Because, first of all, a large percentage of people in this room have periodic trouble sleeping, either falling asleep or getting back to sleep after they've wakened in the night. Currently, and then I say virtually all of you have had problems with sleeping because it's just natural in this age and in this state of our culture. So I know what you're doing, and I know why you're having that problem. It's always the same. You're thinking. You wake up and you think. Thinking is not a passive activity. And I know what you're thinking about, and none of it is good. Because those don't recruit your attention in the middle of the night. In the middle of the night, you have no defense system whatsoever. That's why your dreams are so rich, why the emotions are so acutely felt. Your defense system is offline. And so you have the thought when you wake up about what you have to do at the office tomorrow, or a speech you have to give, or a grade you might get on a test, or this unpleasant encounter you're going to have with a supervisor, or that you're going to have to go talk to the neighbor about the money they owe you, or whatever it is. That's the first thought that comes to mind when you wake up. That is a threat to your well-being. It recruits, and I said this before, epinephrine, cortisol, so it recruits glucose, that gets metabolized, body's ready for action. By thinking that way, you are preparing your body for action, and then you're telling it to go to sleep? It's going, no, sorry. You just stepped on the gas pedal. Now you want us to stop? What we also do, is we look over at the clock, do the math. Right? Well, that's never pleasing. That is a threat over there. Oh my God, I'm only going to get 4 hours of sleep and I have to give a talk. Same thing. Now you're building the energy. We're building energy. So what do you do instead? You not think? No, it's not possible to not think. You give your mind something else to do that produces different hormones. And here's what to do. Focus on your breathing. Just as soon as you wake up, instantly go to your breathing, start counting breaths, stay there, you'll fall asleep. Maybe not right away, but eventually your body gets the message. The message is, I'm not needed. He's just counting breaths. I don't need to help him with that. He can handle that on his own, so to speak. It's what the old version of counting sheep. You give the mind something really simple to do, and the body gets the message that it isn't needed. And it also strengthens the part of the brain that manages stress in general, so the mistakes that we make by responding to stuff as if it were truly threatening when it's not are made less. We can circumvent the threat-based stress response by engaging in mindfulness and meditative practices. And one way for you to get a handle on this is just to do it at night when you're inclined to think. I mean, I could spend hours just on that one slide, so I got to move forward. Okay, cognitive restructuring. How many behavior analysts in the room? How do you like this? Friman is, promoting cognitive restructuring. Everybody in this room uses it. Everybody. Especially the behavior analysts. How can I say that? Because all it means is talking somebody into something. That's all it is. It's just talking somebody into something. We spend all day doing this. I'm doing it right now. This is an act of cognitive restructuring. I'm trying to rearrange your cognitions so they are more commensurate with my cognitions. That's all giving a talk is. So it isn't as big of a deal as cognitive psychology has made it out to be. It's nothing special. It's just a special term. But fundamentally, it's just talking people in or out of stuff. And people make cognitive errors all the time. And they particularly make them if they're anxious, and they make these kinds of errors, this all or nothing thinking. There's nothing in the middle. There's no other alternative. It's really good or it's really bad. And if the person is in a reasonable state, for example, one of the reasons why we'd want them on medication is they are more susceptible to rational conversation when they're calmed down. And so we can get more input. I'm not saying this would make all the difference, but it can make some difference. Magical thinking. Here's the deal. We all have a tendency to do this. Here's our standard of proof in general. My standard, I say your standard too. If you see it clearly and feel it intensely, it's true. If you see it clearly, you see it, and you feel it intensely, that's the way it is. I mean, it's not the way it is. That's just how we are. That's our standard of truth. So if you see somebody in your mind's eye and you see that they are a rectal pore, am I communicating? It's as far as I'm going to go with that image. They are a rectal pore. You see it clearly, and then you feel it intensely, then they are. That doesn't mean they are, but it does for us. And then somebody tries to talk us out of seeing that person that way. It's really hard for them to do that because that's our standard of proof. But that's magical thinking. Just because you see something clearly and feel it intensely does not make it true. It's just the way that we are structured as a species. The people that are on the plane, they get this thought, this plane's going down, and they feel it intensely. That plane is not going down, but try and talk them out of that. They have latched onto this. We tend to give more credence to those kinds of thoughts and feelings than we do any other thoughts and feelings. They seem somehow real because they're so vivid. That's just magical thinking. Filtering is just focusing entirely on the negative aspects of a situation. I took a guy, I took this city boy. He's a professor at the University of Kansas, a professor, a psychologist, a professor of pediatrics. I took him camping in Montana. And I got him a tent, and I got him a mattress, blow-up mattress, and I brought my friends with him. And to be fair to him, to my friends from Montana had a little fun with him around the campfire. But they started very subtly, these are smart guys, talking about grizzly bears. We were in a part of the state where there aren't any grizzly bears. But they weren't telling them that. They were just talking about horrific grizzly bear stories that they'd encountered in all their backpacking trips. And my friend isn't saying a word. He's just silent, listening to this. And then he's got to go down and sleep in his little tent because he wanted to have a one-man tent. And the night, he got a cold that night, and his air mattress went flat within about an hour. And so all night long, he's like, he gets up in the morning, he's just haggard and blue in the face. And that was 20 years ago. And he'll never, ever, he has a 36-foot Winnebago now. And he'll never camp without it. He'll never, ever enter a tent again as long as he lives to spend the night. And it's just from one episode. And we did have a little fun with him, but he never really got hurt. But he's over-generalizing this to all camping. So camping now must be done in luxury. It's not camping, it's glamping for him. Magnification, same kind of thing. Basically given greater proportionally greater weight to failure, weakness, or threat than to success or bravery or positive outcomes. It's like we think of those as lucky. These folks do think of those as lucky, but they think of the mistakes and the failures as that's actually a reflection of how things really are. And emotional reasoning is fundamentally assuming that negative feelings have more, same thing, have more credence. They expose the true nature of things, not positive emotions. Now, I'm going to talk a little bit, I'll do one quick, I'm hustling here because I'm going to end at noon. Packaging is so important because I mentioned we know what to do. There's no question about that. Exposure is what we do. How do we sell it? How do we get them to do it? And that's all dependent upon packaging. And historically, behavior analysts have been terrible at this, with a few exceptions. For example, Nate Azrin, toilet training in less than a day. That sold 3 million copies. But listen to that title. Everybody has to toilet train their kids. Nobody wants to take very long doing it. He packaged that very beautifully. And then inside is a whole bunch of technical behavior analytics stuff. And people were buying it in, like, I don't know if you have any idea how many 3 million copies of a professional book is unheard of. That's more copies than all the behavior analytic books ever written combined have sold. That's just one book. Because it was packaged so well. And then he goes on to Habit Reversal in a Day. That also sold really. This is beautiful packaging, but mostly we're pretty bad at packaging. And like I have a couple of examples up here. I don't think I have time to go into both. I'll give you our guardian angel one. When I work with kids, I always ask the parents, how much of a role does religion play in your life? And then I correspond my remarks. So if they say a very big role and we're Catholic, okay, I got something I can work with. The kid, let's say he's a bedwetting kid. I need him to use the urine alarm. I have a bunch of technical stuff I want the family to do. I know what they need to do. I got to get him to do it. I got to get him to buy the package. So I'm talking to the kid. I'm like, hey, okay, Tommy, do you say your prayers when you go to bed at night? Uh-huh. Well, who do you pray to? Well, I pray to God, and I pray to the baby Jesus. Okay, what do you pray for? I pray so Mommy and Daddy will be all right, and Tommy too. Okay, well, I want you to do something for me, hon. Tonight when you go to bed, I want you to pray to God and pray to the baby Jesus so your parents and your brother will be okay. And I also want you to pray to your guardian angel, because you have a guardian angel. And I know he knows about this because he's Catholic. So I'm not really talking to him. You follow what I'm saying? I'm talking to her. I'm not talking to him, but she's loving this. She didn't like all that like mumbo jumbo about the alarm and the urine retention and the Kegel exercises. I mean, that sounded like good stuff to do, but it still doesn't have a package, it doesn't have a ribbon. But I've sewn it up now, and I put it into something that she can take home and talk to Dad about. And that she can get involved in, because she'll be asking that kid every night to pray to his guardian angel, because I'm telling him, okay, you pray to your guardian angel, and ask the guardian angel to wake you up when you have to go to the bathroom, and that way you won't wet your bed. Will you do that for me? Uh-huh. That's just packaging. I don't know if it has any effect, But I always stick stuff like that in what I'm doing. I'm always reaching into the life of the person in front of me, pulling something out and putting it into my intervention that you would never find in the pages of Java where I got the intervention. Now, I need that intervention from Java. I'm not belittling that at all. I need the technical aspects of this, but that's not enough. The technical part won't sell itself. It needs to be sold, and it's what Mont Wolf called social validity. It needs to be heightened. I don't have time to go into Maslow's hierarchy, but I wish I did. Because I love talking about Freud, Maslow, and Rogers with behavior analysts. Because they tend not to look there for material. And I tell you what, there is material there to use. You can just decode it into behavior analytic terms. So here's our exposure-based treatments. Exposure response prevention, if you happen to be a cognitive behavior therapist. Systematic desensitization, if you're a respondent-oriented behavior therapist. Escape extinction, if you're a behavior analyst. Behavioral and emotional inoculation, if you're Friman. All the same stuff. Basically exposing people to the thing in small amounts so they get accustomed to it down the road. And somebody was asking me questions at the break. Okay. How do you get them to do it? Like the example that was used was selective mutism. Really tough. Really tough. Because the kid is rarely motivated to participate in the exposure. Because the world has reformed around the selectively mute kid to take care of the kid. So the siblings and the classmates speak for the kid. And they're not just instruments of execution for the kid. They are sources of status for the kid. I mean, these selectively mute kids get a ton of attention for being selectively mute. And so I'm going to go over there and I'm going to tell the kid that they no longer want to be selectively mute. They want to just be an ordinary kid now and talk for themselves. What do they get out of that? I mean, if the person isn't going to benefit from the exposure, well, then there's no reason for them to pursue it. That's why I've got a picture of a mouse in an elevator. Like, you can be afraid of mice and be fine in life. You don't have to get over that fear unless you have a bunch of mice in your house and you have to sell it in order to get a mouse-free house. But most people, you know, I mean, I'm a little weirded out by spiders, to be honest. But I can live with fear of spiders. You know, I can kill them, I can avoid them, I can live my life fine and still be a little weirded out by spiders. But I can't really live my life and be terrified of elevators. I mean, this building's fine, it's 4 stories. Remember that building in Chicago? That was 28 stories. There are other buildings in Chicago that are 50, 60 stories. I'm in good shape, but I'm not going to be climbing 50, 60 stories just to go up and see somebody in an office. So that is something I need to get over. If I'm terrified of elevators, I like to travel by train. But I travel 20, 25 times a year. I can't take 20, 25 train trips. The thing on trains is you want to be on time, don't take the train. So if I were afraid, I'm not afraid of flying, but if I were, I'd have to get over that. There's value for me to get over that. If there's no value, they're not going to do it. We're asking them to do stuff they don't want to do. There needs to be a why. Sometimes there's inherent value. They know they want to get over it, and they'll work with you. Sometimes there's no inherent value, in which case you've got to put the value in. And that means extrinsic reinforcement of some sort. There needs to be a payoff of some sort for the kid to engage in the behavior, or for the person to engage in the behavior. Am I making sense here? I have a tough time with selectively mute kids because it's hard to come up with something to convince them that their life would be better if they talk at school. I mean, we've had success there, but there is a reason why there are no rigorously conducted scientific studies on treatment of selective mutism, and that's because it is so hard to treat. And the reason it is so hard to treat is because there's a community of reinforcement that supports the symptoms. And it's really hard to disaggregate and defunction that community because you just get rid of one piece of it. It's like the blob. You get rid of one piece and there's another piece coming into the door, and then there's another piece coming into the ceiling. And it's like the reinforcement's everywhere. And how do you cut it all off? And it's hard to do. Think of a couple of examples. And then I'll show you a data-based one, and then I can, yeah, we'll be on time. We'll be on time. Yeah, we're good. An anxiety-based condition is called being overwhelmed. And I'm sure there are people in this room that know what it feels like. And I know how to treat it. It's really simple. This will work. If you ever get overwhelmed, this will solve your problem. Start something you can finish. That's it. And then when you're done with that, start something you can finish. And then when you're done with that, start something you can finish. Don't attempt anything you can't finish. Don't even think about anything you can't finish. Just think about something you can finish. And that could be open the window, let some air in the room. Finish, good. Every time you finish something, you do access what might be called automatic reinforcement. In colloquial terms, you get a little energy out of it. A completion generates energy, and incompletion takes energy. So the people that are overwhelmed are tending to concentrate on the things that are the most important that they can't get done. It just shuts them right down. We refocus their energy and expose them to completion and incompletion at the same time, giving them the benefit of the completion when they pursue the task. It's the same kind of a thing. It's an exposure to stuff they're trying to avoid. Now, in the steps for systematic desensitization or graduated exposure, you want them to be very small. If they're too big, it's not one step forward, 2 steps back. It's 1 step forward, 25 steps back. You want no fear in the step, or as minimal, like, remember the backward chaining program with the bed? You want those steps to be so small that there's very little likelihood that they're going to have a threat-based stress response. If they have one, that program is over for a while. So you want to slice those steps up really, really small and then throw in some value. So here's a program I did with a little girl that was actually she was an ASD girl that was afraid to go to the bus stop alone. She wanted her mom to walk her to the bus stop every day, which kind of hurt her socially because she was in the 3rd grade. The bus stop was 1.5 blocks away from the house. Mom could see it from the doorway, but the girl wouldn't do it. So I carved up the distance from the door to the bus stop in yards. And her step was, the step in the program was just to go 1 yard. She's done. She gets a reward, and Mom walks her the rest of the way. And she was willing to do that because, you know, a yard, it was just a step out the door. And then for this, she gets reinforcement. And we keep doing this. I don't like push her fast. That's good enough, hon. You're great. This is terrific progress. I just can't believe how well you're doing with this. And we stick on that for a while and then add in the next step. Oh man, this is going great. And this is not on a one-time basis. This is an ongoing basis. Then I have a side conversation with her and I tell her, okay, what can you promise me? Can you promise me a step? Yes. Okay, that's all we're going to work on. That's all we're going to work on. But any time that you want to take more than 1 step, you can if you want. You can have a go for. I don't expect anything for you in the go for. All I want is the promise. But we can always have a go for. And anytime you want to go for more, go for more. And you know what we're going to do? You go for more, we're going to double up on your reward. And that's sort of the formula for all my graduated exposure studies, all my graduated exposure cases. Very, very small steps, very minimal amount of fear in each step, high payoff for completion. A promise and a go for. So I'll give you an actual case. This is a Boys Town kid. This kid, he's a highly athletic, highly handsome, charismatic, 15-year-old kid, 1 year behind in our middle school, biggest kid in the middle school, terrified. Who knows how this happened? Of ladybugs and crickets. And he's the toughest kid in the school. He's the most athletic kid in the school. All the girls in the school love him to death. So you'd think these boys didn't try to figure out ways to taunt this kid. They knew about his fears. They would just tell him, hey Bill, I saw a cricket under your chair. Bill flip out, jump out of his desk, knock his books over, run out of the room, run out of the building. I mean, he just was terrified of these insects. And why, I don't know how that came to be. I just knew it was so disruptive that he was at risk for being expelled from that school. And so they asked us to work with him. And I have a feeling that if we didn't work with ladybugs, I'll tell you why. You can buy ladybugs. You can buy crickets. But when you buy ladybugs, at least in Nebraska, you got to buy 1,000 at a time. That's a lot of ladybugs. But you can buy crickets one at a time because people feed them to their tarantulas. And so we work with crickets. But I think when he thought of crickets, it wasn't like what you and I think of. Maybe that's what you and I think of. I think this is more like what he had in mind. And it terrified him. So here's our graduated exposure. First was holding a jar with crickets in his hand. The next was touching a cricket with his foot. Then closing his eyes for 60 seconds in a room where there was crickets. Then picking up a cricket with tissue. Then picking up a cricket with a gloved hand. Then holding a cricket for 20 seconds with a bare hand, so on. All the way up to holding a cricket in each hand for 20 seconds. Now, who in here would like to do that? I mean, that's a big step, right? I mean, even I'm a little creeped out by thinking of that. So these steps are pretty big, but this kid was really willing because he was so embarrassed. So these are big steps. For the standard program, I wouldn't want them to be this big. And again, here's the data. Oh, there. Okay, so you got 3 conditions. You got no bugs. That means I go in the room, I examine the room, top to bottom, and I turn to him and go, man, I checked this out. There's not a bug in here. One is, say bugs. I go, look, I know there's crickets in here somewhere. They're all over probably. And then one is bugs, where I got a jar with bugs and I put them on the floor. Those are the 3 conditions. And then what he has to do is be in that room and complete math problems. And those are the differential rates. It's like, oops. Remember the graph. I had him do these math problems, and we got a nice rate with the no bugs condition, a little lower rate with the say bugs condition, and a very low rate with the actual bugs condition. And then we put the program in place, and he began to increase his rate of problem completion dramatically, and then it fell off, down below baseline. And we were a little puzzled by this, and then we realized, although we were rewarding him for doing his exposure program, we gave him big rewards for completing those steps, we gave him nothing for the math problems. And I think he just had it with math. He's sitting in there doing the math with the bugs in the room, you know, like, not bugs, like dinosaurs and wild wolves and angry dogs. That's what it was for him. He's in there doing math with all that thread around, and he's getting nothing for it, so I think he's just like, I'm not doing this anymore. So we started paying him handsomely for completing math problems. That thing just took off. So we added value for doing the math, and we added value for doing the steps. And the terminal step of the entire program was completely serendipitous. My co-author goes over to the middle school. He's watching from the back of the room. Our client doesn't know he's there. He looks under his desk. He's looking around. He sees something. He's got his eyes on it. He goes up to the teacher's desk. He gets some tissue. He goes over and he grabs it, scrunches the tissue up and throws it in the wastebasket. My co-author waits until the class empties and goes and looks in the tissue, and there is a big fat cricket inside the tissue. Completely took care of that condition. So, let me end on this note. A typical treatment, demystify it. I've been demystifying now for almost 3 hours. I'm trying to take the mystery, the mystique out of anxiety, for example. Just call it fear of stuff that's not dangerous. That's all it is. There's nothing mystical about that. We all have some of it. Some people have a lot of it. Give it a name, externalize it. Establish a fear hierarchy, which we did with those crickets. Make the steps very, very small. Establish exposure incentives. Make value in the steps occur. Revise parent-child interactional stuff like helicoptering and conversations that involve, if it's okay, sympathetic conversations. Schedule worry time for the kid. Relaxation skills, breathing skills, and social validity mumbo jumbo, which is what I was saying with the guardian angel. Just add something in that makes it more appealing for the parent. So, I'm not going to have time for questions. I'm sorry. Now, let me say this. Skinner's vision of behavior analysis was that it was a generic science that would one day be seen to be relevant to all of human behavior. That hasn't come to pass. That has not come to pass. But the science has flourished in one tail of the distribution, and in that tail are persons on the spectrum and persons with developmental disabilities. And I'm looking at a room full of people that have achieved that success or helped achieve that success. I can't acknowledge it enough, because those populations have been more mistreated throughout the annals of history than any other populations of human beings. There was a time when they were thought to be inhabited by devils. If you want to find out how they were treated in the annals of history, look up the Malleus Maleficarum and see what kind of treatment that they got then. All the professionals in the history of our species have seen these populations and thrown in the towel because they thought they couldn't be helped. And they've been left in the dark ages of the darkest part of our species for centuries, millennia, and then along comes the behavior analytic crowd. And people like yourselves interested in these populations, if we brought them out of the dark ages and out of the dark light into the bright light that we enjoy, so they have lives with possibilities just like we have in our lives. I can't acknowledge that enough. Thank you so much for your service. Thanks for being here.
Thank you so much. What an amazing presentation. This is session 72, just in case you need reminding. And your verification code is PUT789. P as in popsicle, U as in umbrella, T as in trampoline, 789. Thank you.
What's that?